Morning, everybody. I shouldn't be here. I'm Fabio Miraldi. I shouldn't be the president. The president was Professor Pillari, who's unfortunately not present, and he apologizes for that. I apologize for my English, which is not perfect, but I will do my best. To the candidates, be on time, please, because we are short of time. And to the audience, it is a happy celebration. I understand that, but also a solemn ceremony. So be quiet and applaud when it is the right time. No whistles, please. You know, it's a ceremony. Thanks to Domenico Della Peruta. We couldn't do without him, to Antonella, who's dealing with the candidates. And I think we can start. And I call the first candidate with Matteo Calafati. Sorry. The supervisor is Professoressa Cristina Lematola. I ask her to introduce the candidate, please.
Thank you, President, and I'm very happy to introduce the work of Matteo Calafatti that joined our lab about 1 year ago with his enthusiasm on a project that using a preclinical model of amyotrophic lateral sclerosis investigated the bidirectional communication among the immune cells, glial cells, and neurons. And he worked hard in this period. He obtained very interesting results, and I'm very happy that he can present them to you today. Thank you, Matteo.
Thank you very much to Professor Lematola for this very warm welcome, and good morning, everyone. Can I possibly lift it a bit? Or just hold it. That's fine. So, shall I start? The thesis project I've been focusing on deals with immunomodulation in the transgenic mouse model of amyotrophic lateral sclerosis as a potential therapeutic target. Here it's not sliding, unfortunately. Okay, here we go. Just a bit of background. ALS is an invariably lethal neurodegenerative disorder characterized by the progressive loss of both upper and lower motor neurons, with an age of onset in between the 5th and the 6th decade of life as an average life expectancy of only 3 to 5 years. Therefore, a disease for which there is a critical unmet need for effective disease-modifying therapies. The pathogenesis involves the 4 major pillars: a loss of function with impaired ROS scavenging, a toxic gain of function with protein aggregation, glutamate excitotoxicity, and neuroinflammation mediated by the immune system and a CNS microenvironment, which is a pillar we have been selectively focusing on. Focusing on neuroinflammation, interesting is to notice that in one way or another, virtually every cell of the innate and adaptive immune system play a role in the pathogenesis of ALS. Anti-inflammatory and neuroprotective factors sustain the earlier, slowly progressive phases of the disease, whereas pro-inflammatory and neurotoxic factors become more prominent in the advanced, rapidly progressing phases of the disease. Therefore, a potential therapeutic strategy is provided by immunomodulatory antibodies, as in the case of natalizumab. Natalizumab is a recombinant, monoclonal, humanized antibody, which is selectively targeting alpha-4 containing integrins expressed onto the plasma membrane of white blood cells and selectively interacting with adhesion molecules, which are expressed onto the surface of activated endothelial cells, in an interaction that is required for firm adhesion and subsequent extravasation in the peripheral tissues. By blocking this interaction, natalizumab blocks the infiltration of detrimental immune cells inside the central nervous system. We're talking about a drug that is already approved for the treatment of relapsing and remitting multiple sclerosis, which is another neurodegenerative disorder. The aim of the thesis was to evaluate the effectiveness of natalizumab in two different transgenic mouse models of ALS, the SOD1 mutated and the TDP43 mutated, with a special focus on CNS immune infiltration, the modulation of the inflammation, special focus on astrocytes, and last but not least, the effect on overall life expectancy. This slide summarizes our materials and methods. Briefly, we performed survival analysis with the Kaplan-Meier method, fluorescence activated cell sorting, immunofluorescence, high throughput RNA sequencing, and last but not least, the real-time polymerase chain reaction. The data we gathered over the last 2 years, natalizumab significantly improves life expectancy in the SOD1 and the mouse models. On the left side of the screen, you can appreciate on the right side, the survival analysis. According to which natalizumab significantly improves life expectancy by approximately in approximately 5 days in the TDP43 mutated mouse model. Our survival data directly correlates with our FACS data, according to which natalizumab significantly reduces red blood cell infiltration in the spinal cord of SOD1 mice. In the left insert, you can appreciate our ALS control mice, characterized in fact by a thick CD45 high leukocytic infiltrate. On the right insert, our ALS treatment group, characterized by a much reduced CD45 high leukocytic infiltrate. Even more important, our survival data correlates with our immunofluorescence data, according to which natalizumab treatment significantly reduces motor neuron loss in the SOD1 mice. In the left insert, you can appreciate our healthy control mice. In the central insert, our ALS control mice. And in the right insert, our ALS treatment group, demonstrating how natalizumab partially rescues the number of motor neurons and significantly slows down the pace of neurodegeneration. Now, with this data in our hands, we decided to take it even further and try to understand what happens at the level of the CNS microenvironment, selectively focusing on astrocytes. RNA sequencing of astrocytes related to the spinal cord of ALS with mice demonstrates that these astrocytes are characterized by a less pro-inflammatory and a more anti-inflammatory profile. After extensive pathway analysis, we decided to focus on 2 candidate genes, which had never been described before in the context of ALS mediated or ALS astrocyte mediated pathogenesis, which is LPAR1 belonging to the pro-inflammatory group and ADCYAP1 belonging to the anti-inflammatory group. We further validated with these 2 genes the means of real-time polymerase chain reaction, and you may appreciate on the left side of the screen, significantly reduces the expression of pro-inflammatory LPAR1, and on the right side of the screen of the same treatment, significantly improves the expression of ADCYAP1. Therefore, enabling us to speculate that natalizumab treatment effectively modifies astroglial phenotype, either directly as a consequence of a reduced interaction between infiltrating immune cells and astrocytes, or alternatively, indirectly as a consequence of reduced stress signals generated by degenerating motor neurons. So to conclude, our studies confirm the previous hypothesis according to which inflammation contributes to ALS progression, and further demonstrated that natalizumab immunomodulatory properties slow down motor neuron degeneration, skew astrocytes toward a less pro-inflammatory phenotype, and increase life expectancy in 2 different transgenic mouse models of ALS, therefore providing a reliable preclinical evidence for the efficacy of the drug, and hopefully bridging the gap into in vivo natalizumab therapeutic testing. Thank you very much. And just to conclude with a note of inclusivity, this is a picture of Roberto and I. And this picture was taken a month ago at the Gillette Marathon World Championship. The Gillette Marathon is an Olympic race in which every team pushes a special wheelchair to the finish line, meant to raise awareness around disabilities and give everyone a chance to run. Thank you very much again, and if you have any questions, we'll be happy to answer.
Asking the committee if there are questions or comments. Just one brief question. How far is the utilization of natalizumab in humans? You can take off the mask.
Okay, thank you very much. Thank you very much for the very interesting question. Unfortunately, I couldn't elaborate more on the presentation, mostly as a matter of time. But natalizumab is currently FDA approved and EMA approved for the treatment of relapsing and remitting multiple sclerosis in humans. And we are talking about a drug that in the context of multiple sclerosis has provided dramatic results compared to the standard of care in multiple sclerosis, which is mostly glatiramer acetate and interferon beta, characterized by a reduction of the annual relapse rate of approximately 15 to 30%. Natalizumab reduces the annual relapse rate of approximately 70%, therefore has dramatically changed life of patients with multiple sclerosis. And in the US, is also FDA approved for the treatment of Crohn's disease.
Thank you very
Thank
much.
you very much.
Are you satisfied? Yes. Next candidate is Franziska Doschwein. The supervisor is Professor Gianluca Mennini. The title of the thesis is The Prognostic Role of the Comprehensive Complication Index for the Risk of Hepatocellular Carcinoma Recurrence, the CCI score. Can I ask you to introduce the candidate, please?
Good morning, President. Good morning, colleagues and everybody. It's a pleasure to introduce Franziska and her work, her thesis regarding the role of this comprehensive complication index. It's a model to try to identify risk factors for the recurrence of hepatocellular carcinoma after liver transplantation. It is a very interesting argument based on a big international work database, and especially, let me say, in these days when we are celebrating here in Sapienza the 40 years of the first liver transplantation performed in Italy, just in these days in this institution. So please, Francis.
Thank you, Professor, for your kind attention, and good morning,
Sorry,
everyone.
Francisco, you can take off your mask
okay.
during the presentation.
Okay,
We
thank
can hear
you.
better.
Thank you, Professor, for your kind introduction. Good morning, everybody. Okay. Liver transplantation is the best approach for end-stage liver disease and for hepatocellular carcinoma. Liver transplantation is the best treatment for hepatocellular carcinoma since it allows to remove the malignancy and also to target the underlying hepatic malignancy. Not all patients affected by hepatocellular carcinoma can benefit from liver transplantation, and as a matter of fact, patients who are not properly selected for liver transplantation have a high risk of recurrence and poor outcomes. For this reason, in 1996, Mazzaferro et al. Introduced the Milan criteria, which are used to select hepatocellular carcinoma patients. Patients meeting these criteria have an overall survival similar to patients who undergo liver transplantation for reasons other than hepatocellular carcinoma. Recently, new criteria have been introduced in order to increase the number of patients eligible for liver transplantation, and these criteria include the biological behavior of the tumor and not only the morphology of the tumor. Despite the use of such criteria, the risk of recurrence of hepatocellular carcinoma after liver transplantation is still high. During the past year, the need for models that predict the risk of recurrence has emerged, and multiple models have been proposed. In our opinion, postoperative complications play a pivotal role in the postoperative outcome and in the risk of recurrence. And for this reason, postoperative complications should be integrated in recurrence models. Postoperative complications can be reported with the Comprehensive Complication Index, which is a tool used to report them based on the widely recognized Clavian-Dindo classification. In the CCI, each complication is graded according to its severity, then all complications are summed up, and then a formula is used to obtain a score that ranges from 0 to 100, where 0 corresponds to no complication and 100 to death of the patient.
The aim of our study was to compare two groups of patients affected by hepatocellular carcinoma undergoing liver transplantation in order to identify factors that can influence hepatocellular carcinoma-related death. We performed a retrospective international multicenter observational study with a population of 1,121 patients with a diagnosis of hepatocellular carcinoma who underwent liver transplantation between 2005 and 2019. In 7 different centers, which were in Italy, Sweden, and Belgium. The population was stratified in 2 groups, a high CCI group with a score higher than 42, which was more numerous, and a high CCI group with a score higher than 42. In order to avoid the risk of selection biases that could arise due to the non-randomized design of the study, we performed a balancing of the 2 groups with the IPTW method. After balancing the 2 groups, four models were constructed, and in order to focus on identification of factors that could influence, first of all, on the hepatocellular carcinoma-related death, which was the main objective of our study, but also on overall death, recurrence, and early recurrence. What we found was that, not surprisingly, tumor-related cover rates were statistically correlated with increased odds in all models. What was of our interest was the fact that a CCI higher than 42 was found to be a relevant factor for hepatocellular carcinoma-related death with high odds. A CCI higher than 42 was not only associated with increased odds with the primary objective of the study, but also with the secondary objective of the studies, which were overall death, overall recurrence, and early recurrence. As we can see in this graph, at 5 years from liver transplantation, there was a big difference between the low CCI group and the high CCI group in terms of hepatocellular carcinoma-related death. As a matter of fact, at 5 years, the low CCI group had a death rate of 7%, whereas the high CCI group had a death rate higher than 13%. What was evident in our study was the fact that postoperative complications have a big impact on the postoperative outcome, and they are related to the risk of recurrence and death. A possible explanation to this phenomenon is the fact that postoperative complications can cause a derangement in the immunity, which may promote micrometastatic cancer cell growth, which results in recurrence. Furthermore, impaired immunity may result in a more aggressive nature of the recurrent tumor, causing an increased hepatocellular carcinoma-related death. So in conclusion, we found that the CCI is associated with hepatocellular carcinoma-related death, overall death, early recurrence, and recurrence. Furthermore, we also observed that that in the low CCI group, after recurrence, patients had a better survival compared to patients with a high CCI group and the recurrence. And probably, again, this is explained by the fact that patients with fewer complications experience less derangement of immunity, which would otherwise cause a more aggressive nature of the tumor and recurrence. Furthermore, in our opinion, other studies are needed to validate the integration of the CCI in recurrence models, such as the retreat score. This would allow to tailor immunosuppressive therapies and adjuvant therapies according to the risk of each specific patient. Furthermore, it will also allow to determine the best surveillance strategy for each patient. In the past, Meth et al. Have already proposed a surveillance strategy as reported in this table, which was based on the risk of each patient of recurrence reported with the retreat score. Thank you all for your attention, and if you have any questions, I'd be glad to answer them.
I'm asking the committee questions or comments. Yes?
No real correlation has been found with viruses because we consider actually complications. The CCI is based on the Clavian-Dindo classification, and this type of classification reports complication depending on the management of the complications, so whether therapies were needed or not, whether a surgical intervention was needed, but there is no distinction between different types of viral infections, although infections are also, of course, taken into consideration in this score. Yes.
Okay, thank you very much indeed. Gianluca, are you satisfied with your candidate? Yes.
Okay, thank you.
Thank you very much. Candidate is Margherita Di Giorgi. I hope it is correct again. Supervisor is Professor Fabio Midulla, who is not here, and he apologizes for that. On behalf of him, there is Professoressa Raffaella Nenna, and I would like to ask her to introduce the candidate, please.
Thank you, President, and it's a great pleasure for me to introduce today Margherita Di Giorgi. She has had a distinguished internship at our pediatric clinic over the last years. She worked hard both in clinics and in research, and she took part in this study from the very beginning, in involving patients, enrolling patients, analyzing data, and discussing results. Finally, she proved to be a very kind person. Today, she will discuss a study on a potentially powerful pathogenetic marker in bronchiolitis that is a very common disease with a wide clinical spectrum. Margherita, please focus on the hypothesis and discuss your results.
So good morning, everyone. Thank you, Professor, for your presentation. Thank you to the Commission and to the President. So today I will be presenting this study that we performed about the follow-up of infants with bronchiolitis and the role of this very new marker, which is BDNF, on the respiratory function tests and respiratory outcome. Bronchiolitis is the most common and most seen acute inflammatory pathology of the lower airways in infants below their first year of life. And it is a seasonal viral illness which is mostly caused by the respiratory syncytial virus, followed by rhinovirus, and more rarely by metapneumovirus and parainfluenza viruses. It is a very, very much discussed pathology because of several reasons, among which the fact that it's the most common cause of hospitalization in this age group, accounting for a very big burden, economic burden on the healthcare system and on the families. It is characterized by the absence of an efficacious therapy. So as for now, we can only perform a support therapy on these infants. And very importantly, it has a very variable clinical presentation and an unpredictable evolution in time. So the problem with bronchiolitis is that to date, there are no severity indexes that allow us to predict the short and long-term outcomes of these patients. And a lot of markers, a lot of tests are being studied. We focused on the tidal volume flow volume loop and the serum marker BDNF. The tidal volume flow volume loop is a new, rapid, non-invasive, and repeatable test that can be performed on infants during their spontaneous breathing and is able to measure the degree of airways obstruction in these infants. We performed this test in these patients while they were asleep, with a mask that was able to cover their nose and their mouth in order to not to allow any air leak. The most important parameter is the TP/TF over TE ratio, which means time to peak tidal expiratory flow as a percentage of the expiratory time, that when found below 25% is indicative of a lower airways obstruction, which is characteristic of bronchiolitis. BDNF, on the other hand, is a widely expressed protein that is found in many tissues of our body, also in our lungs, and it's basically present in all of the cells of our lungs, and it has been associated in adult patients with an increased serum level of BDNF in COPD and asthma patients, while it is being seen increase in the bronchoalveolar lavage of infants with children in general with lower respiratory tract infections caused by RSV, which is also the most common pathogenic virus of bronchiolitis. So we were wondering if there is a role of BDNF in the bronchial hyperresponsiveness also in bronchiolitis.
So our aims were to correlate the tidal volume flow volume loop with the clinical manifestation and the severity, to correlate the BDNF levels in the serum of our patients and study it as a disease severity indicator during the hospitalization, and to correlate this BDNF value with the tidal volume flow volume loop, in particular to the TP-TEF over TE ratio that indicated an obstruction of the lower airways. So from October 2021 to December 2021, we enrolled 129 patients that were admitted to the pediatric ER of the Policlinico Umberto I Hospital with a diagnosis of bronchiolitis. They were then admitted either to the short observational unit in the majority of cases, and in a minority of cases also into pediatric intensive care unit. Upon admission, all of the infants were assigned a clinical respiratory score based on their clinical presentation, the severity of the physical examination, and their peripheral saturation. And we asked the parents an anamnestic questionnaire where we investigated the presence of smoking history in the family and the presence of a positive family history for atopy. Then we performed on all of our patients a nasopharyngeal aspirate in order to investigate the cause of bronchiolitis of the disease. And then we studied the clinical course during the hospitalization. At discharge, all of our patients underwent the tidal volume flow volume loop test while asleep, as I was mentioning before, and 58 of our patients underwent blood withdrawal in order to study the levels of BDNF in their serum. We found our sample was basically half and half males and females with an average age of 3.6 months. Very important in this graph is the fact that school siblings were present in 80% of the sample, which is very important because older brothers that went to school were the main source of the virus, which arrived home to these infants. Most of them presented with a pretty typical presentation with cough, increased work of breathing shown as diaphragmatic, intercostal, and jugular retractions. Some of them had fever, and about half of them had localized or diffuse breath sounds upon auscultation. So the first important correlation that we found was between the TP-TEF value, TP-TEF over TE value, in those patients with a more severe clinical presentation, represented by the presence of localized breath sounds during the physical examination. Indeed, we found that those patients with this auscultatory finding had a value that was well below the pathologic value that, as I mentioned before, is 25%. We can see that those who had these auscultatory findings had a 20% TP-TEF over TE value, while those who did not have these auscultatory findings had a value that was above the pathologic range, so 26%. Then we found also a significant correlation between the level of BDNF in the serum of our patients and a more severe clinical presentation, again, shown this time by the presence of oxygen supplementation. Those infants who needed oxygen supplementation during the hospitalization were found with an average BDNF level lower than those who did not need oxygen. We then set a threshold at around 9,000 picograms per milliliter of BDNF that allowed us to divide our patients into two groups, those who had a BDNF below 9,000 and those who had it above 9,000. And as we can see from this graph, this correlation is given by the fact that 57% of those infants who needed oxygen during supplementation, 57% of infants with a BDNF below 9,000 picograms per milliliters had the need of oxygen during their hospitalization, while among those who had the BDNF above our threshold, only 26% needed oxygen. This correlation was made stronger by the presence of fever, positive smoking family history, and diffuse breath sounds upon auscultation. Finally, we decided to correlate these two parameters, so the TP-TEF value over TE and the BDNS levels in the serum of these patients, to find again a correlation. And we found that among those infants that again were in the group of BDNF below our threshold, 80% needed oxygen, and the TP-TEF over TE below 25%, so below the pathologic range. So this study told us that basically there is a potential role of the TP-TEF over TE ratio in the infants with bronchiolitis, and also a role of BDNF serum levels as severity indexes for this pathology that can help us in the future to have a better management and, more importantly, a prognostic evaluation of these patients. Thank you very much.
I'm asking the committee if there are questions. There are not one mind. BDNF can guide us on prevention therapy in the patient if the patient is asymptomatic.
We did not actually analyze this, we found a more severe correlation, a more severe clinical presentation in association with the lower BDNF levels. But if we are actually going to investigate the receptors of BDNF in the serum of these infants to realize what is the mechanism why BDNF is decreased in these infants. And if we find relevant and important results, I think it might be useful also to use it in asymptomatic patients, even if actually asymptomatic patients are not admitted into the hospitals, because they're usually like the diagnosis of bronchiolitis is performed on the symptoms, and the hospitalization is based on the fact that these infants cannot eat anymore, because the fact that they cannot breathe properly brings them to have a lower food intake. So this is the main criterion to hospitalize these patients. But yeah, it could potentially have a role, maybe.
I'm satisfied with the answer. Are you satisfied? Well, okay.
Thank you
very
Thank
much.
you very much.
Next candidate is my candidate, actually. Emanuela Curta. Emanuela is undoubtedly the best student I ever had so far, even though the future. And her thesis was born a few months ago when she met the most famous and important cardiac surgeon in the world, Professor Sermat Diaco, who was very impressed by her. And he was so impressed that he gave her the opportunity to follow up his patients operated by a new technique called autologous loose jacket to preserve the aortic meat in the Ross operation. And to be honest, I didn't write a single word of this thesis. She wrote everything on herself. And actually, she is able to write a paper because she has got already 5 papers on the Scopus, which is great for such a young woman. So after all I have said, you must do a brilliant presentation.
Try.
Okay.
So good morning, everyone. Good morning to the committee. Thank you, Professor, for your wonderful introduction, and thank you for everything you have taught me for the past 2.5 years. Today, I am more than proud to present to you my thesis on the long-term follow-up of the autologous loose jacket technique for the pulmonary autograft procedure. So, to introduce the pathology, the aortic valve is the one most commonly involved in valvular heart disease, which can be generally divided into acquired and congenital valvular disease with 2 pathophysiological substrates, stenosis and regurgitation. Although acquired disease tends to present more frequently in the elderly, it can present earlier than normal in the presence of an anomalous substrate, such as a congenitally bicuspid valve, which is actually present in 2% of the general population. So we are facing a very clinically important issue. Such disease may need an operation, but treatment is not always simple, especially when we're talking about young individuals. Replacement with a prosthesis, either a mechanical prosthesis or a bioprosthesis, does not leave room for growth. Unlike with a bioprosthesis, people that choose a mechanical valve may not usually need a reoperation down the way, but they do need to follow a strict anticoagulation regimen that can become problematic for an active individual, which is usually the case with young people, or for someone who desires a pregnancy. Another option is valve repair, but unfortunately, it's not performed by many surgeons and it yields very variable results. So, as an alternative, Donald Ross presented the pulmonary autograft procedure in 1967, which takes the patient's own pulmonary valve to replace a diseased aortic valve, while a homograft from a cadaver is placed in the pulmonary position. As you can see, it offers numerous advantages. It has growth potential, no need for anticoagulation, a low risk of thromboembolism and endocarditis. It has been blamed to cause a double valve disease when there was only a single valve disease, but the data paints a different picture. Thanks to the excellent hemodynamics, the life expectancy, the sex and age matched life expectancy of individuals with the autograft matches perfectly the one of the general population. One important caveat has been identified, which is the risk of autograft dilatation as the pulmonary valve is implanted in the aortic position. So it goes from a situation of very low pressures to a situation of very high pressures. Several methods have been proposed to support the neo-aortic route, and one of them is the autologous pericardial wrap, which simply takes a piece of the patient's pericardium to create a jacket around the new aorta, ex-pulmonary valve, and a piece of the pulmonary artery to support the autograft. It offers support to the neo-aortic route, and importantly, it does not limit growth, which is one of the main points of the Ross procedure, and it does not limit expansion of the route during the cardiac cycle. So far, 70 patients worldwide have received the loose jacket. So our study aimed to determine the long-term results of this modification when compared to no external support. So to compare the results, 3 patients have been identified, operated, as said earlier by Sir Magdi Yaqub, operated at our hospital from 2000 to 2015. 2 of the patients received the loose jacket modification, while one of them did not receive any type of external support. And we decided to follow the patients with cardiac magnetic resonance. Our endpoints included, of course, survival, quality of life as described by the patient, autograft and or left ventricular dilatation, and valvular competency. So our first patient is a 55-year-old male who underwent the Ross procedure 22 years ago. He did not receive any type of external support. He did undergo reoperation for endocarditis of the homograft, so the piece from a cadaver in the pulmonary position 7 years after the original procedure, but the autograft was left untouched. On MRI, we saw that the aortic root had a diameter of 52 millimeters. Aortic valve regurgitation was characterized as mild, and left ventricle dimensions were increased for age and sex, but normal when corrected for body surface area. Next, a 29-year-old female. She presented in perfect conditions. This is her 10-year follow-up, and she originally underwent the autograft procedure with the addition of the loose jacket. And as you can see, all parameters on MRI were normal. Next, we have a 27-year-old male who underwent the procedure 7 years ago. His aortic root, his neo-aortic root, has normal dimensions. Valve regurgitation was characterized as mild to moderate, and we see that left ventricular dimensions are increased both for age and sex and when corrected for body surface area. But here I would like to point out that those were the preoperative dimensions of the patient's left ventricle. So our results, we had no early or late deaths. All patients presented with an excellent quality of life. None of them reported any limitations in their daily life. And as you can see, highlighted in green are the 2 patients with the loose jacket. This is the the ESC consensus paper that shows us the normal dimensions of the aorta. And the one patient who did not receive the loose jacket has a dilatation of the neo-aorta at the level of the sinuses that is characterized as moderately abnormal. It does not reach the cutoff for reoperation. As you can see, it is 55 millimeters, but 52 millimeters in a 55-year-old male is already a bit much, and it is certainly much closer to the surgical indication compared to the values observed in the jacketed patients. So, of course, the patients were very few, so this study does not allow us to perform a statistical analysis, and follow-up times varied for every patient. So we could not really determine the dilatation rate for every patient. This means that we need to perform a watchful follow-up to see if and when the patients will eventually need a reoperation. However, so far, results seem very promising. The loose jacket is a very simple technique that we believe can help more people benefit from the pulmonary autograft procedure. Of course, we need to validate the superiority of the pulmonary autograft with the loose jacket modification in larger population trials. Thank you for your attention.
Ask you if there are questions. There is a question there, please.
Thank you very much. Worldwide, yes. Okay, so the problem with doing a large population study is that so far the autologous loose jacket is performed only by Sir Magdi Yacoub and his group of surgeons. So they perform it in people that are undergoing the Ross procedure for the first time, because when you are doing a reoperation, you can't actually find a good pericardium to create the jacket. So we would need to follow up on each and every one of these patients and see what the results are. There are more patients currently undergoing this procedure, so there's some future to it. So yeah, it's not going to be a very large population study.
Thank you very much for your question. Thanks, Emma.
Thank you, Professor.
Candidate is Ilam Adzenkut. Is that correct? The supervisor is Professor Ludovico Muzzi. The title of the thesis is Adenomyosis and Infertility, a case control study on ovarian reserve and outcome of the IVF procedure.
Thank you very much, Mr. President. Ladies and gentlemen, I'm happy and proud to introduce Ilan. This is obviously, like most of the theses today, a very sub-specialty topic, which is IVF, in vitro fertilization. Although the first test tube baby will be like 44 years old this summer, there is not a lot of research on some topics. One of these topics where there's almost no research at all is adenomyosis, a very common disease in gynecology, and the results at IVF. So I'm willing to hear your presentation and the results, which I believe will contribute to the international.
Thank you very much. Okay. Adenomyosis
is a benign gynecological disorder that consists in the invasion of the myometrium by the endometrial stroma and glands. It has a prevalence that ranges from 5 to 70%, and it is asymptomatic in 30% of the patients. From the symptomatic patients, instead, the main complaints are menorrhagia, dysmenorrhea, and metrorrhagia. It is also highly associated with endometriosis, uterine fibroids, and infertility. Indeed, we can find a prevalence of adenomyosis in women undergoing assisted reproductive technologies that ranges from 20 to 25%. Ovarian reserve is an important concept in infertility because it consists in the pool of primordial follicle that a woman has, and after the age of 30, it starts to decline, and fertility declines in parallel. We have some markers to measure it, for example, follicular stimulating hormones, anti-mullerian hormone, antral follicle count, and estradiol level. Anti-mullerian hormone is very useful because it has very little intracycle and intercycle variability. It is a quantitative marker, and it is used very frequently in pre-treatment assessment in controlled ovarian hyperstimulation in order to give the right dosage and to minimize the risks. Infertility affects many couples all over the world, and many of them refer to fertility units to undergo assisted reproductive technologies. And in vitro fertilization and intracytoplasmic sperm injection are two advanced assisted reproductive technologies that differ mainly in the fertilization process. Indeed, in IVF, the sperm is allowed to fertilize the egg by itself in vitro. In the ICSI, we have the sperm injection inside the oocyte. But for the rest, the steps are the same. So they start with ovarian stimulation, then there is the egg pickup phase. After that, there is the fertilization, of course. We wait for the embryo development, and eventually we transfer the embryo inside the uterine cavity. In this study, we wanted to evaluate women undergoing IVF and ICSI with adenomyosis versus a control group, and we wanted in particular to see their AMH level before the stimulation, the clinical pregnancy rate, and if there is any correlation between the AMH and the outcome of these procedures. Furthermore, we wanted to see their pain symptomatology, their transvaginal ultrasound adenomyosis characteristics, and the number and quality of both the oocytes and embryos. So we did a retrospective study in which we selected 60 patients with infertility, 30 of which had adenomyosis and 30 without. And we included women with age between 18 years old and 43, with primary or secondary infertility that underwent less than 3 embryo transfer, that have done all the necessary exams, and of course that sign an informed consent. We excluded women without these characteristics, with current neoplasia or current infection. And we did a careful clinical history focusing on the symptomatology before the stimulation. We also did a transvaginal ultrasound, and of course, we evaluated their serum AMH level. We tried to minimize the biases between the two groups by matching them by age and BMI, and we found out that the main type of infertility was primary infertility in both of the groups. Also, the main infertility factor was PCOS in both of the groups. Instead, endometriosis was mostly correlated with adenomyosis, confirming what is found in literature. We also saw that the AMH in focal adenomyosis was lower than that of diffuse adenomyosis, which instead was comparable to control. The clinical pregnancy rate of focal adenomyosis, unfortunately, was 0. The one of diffuse adenomyosis instead was lower than control. We didn't find any significant difference with respect to the number of oocytes in the groups. We found out a little bit lower quality in focal adenomyosis. And we also find out that there is a positive correlation between the AMH of diffuse adenomyosis and the clinical pregnancy rate, as well as the AMH of control and the clinical pregnancy rate. So what can we conclude from this study? First of all, this study suggests that adenomyosis seems to have an overall negative effect on assisted reproductive technology outcomes. Especially focal adenomyosis seems to have worse outcome with respect to both diffuse and controls. It seems that adenomyosis doesn't affect the quantity of oocytes, but it may affect their quality. And also that adenomyosis affect negatively the uterine environment, leading towards clinical pregnancy rate. So probably patients would benefit from medical treatment after the embryo transfer in order to improve their adenomyosis and eventually also the outcome of assisted reproductive technology. However, we need future studies with larger sample size. Thank you very much.
Just a little question. If I have well understood adenomyosis, it is not a contraindication for the IVF procedure at all. Is that right?
Yes.
So this is the take-home message.
Yes.
Okay.
Yes, it's true.
Okay. Thank you very much.
Thank you very much.
Next candidate is Giovanna Mustafa. Supervisor is again Professor Medicina. The title of the thesis is Follicle Curettage of oocyte pickup in the IVF program, results of randomized clinical trial. Please,
Thank you very much again, Mr. President. And again, same concept is valid for Giovanna. There is not a lot of research going on. And what surprises us in the context of this presentation, it's that during the final step, one of the final steps of the in vitro fertilization procedure, that is, with a needle, we go into the ovary and take out the oocytes. There is a maneuver that some of us do and some of us don't, which is moving the needle, trying to get maybe more oocytes. What is surprising, and there is no study at all to compare this maneuver to omitting this maneuver. So we had the idea to do a randomized clinical trial on this simple maneuver, and let's hear what the results are.
Thank you, Professor Muzzi, and good morning, professors, colleagues, and families. I will start with a little background. So infertility is defined according to World Health Organization as the failure to achieve clinical pregnancy after 12 months of regular and protected sexual intercourse. It may be due to male factors, female factors, or both, or even idiopathic. The treatment of infertility include direct correction of the specific causes if identified. Otherwise, we can proceed to either intrauterine insemination or assisted reproductive technologies, including in vitro fertilization or shortly IVF. In our department, we use the protocol which start with multifollicular growth stimulation via gonadotropin injection, followed by downregulation of pituitary gland to prevent spontaneous ovulation. Then we monitor the patient to identify the optimal timing for ovulation triggering, which is done by HCG injection 36 hours before the oocyte retrieval or pickup. The pickup is done today by transvaginal ultrasound-guided approach. It's usually done under general anesthesia or sedation. There are several variations of this technique regarding the type of needle we use, if it's done by fluid aspiration alone or with follicular flushing or
follicular coriting, as Professor Muzzi introduced, that involve a gentle and rapid rotation of the needle in a clockwise and counterclockwise manner after fluid aspiration. Our objective in this study is chiefly to evaluate the impact of coriting in terms of oocyte quality, including oocyte retrieval rate, which is defined as the number of oocyte retrieved divided by the number of follicles. The second primary objective is the number of oocytes in metaphase 2, which have an excellent quality. Secondly, we wanted to evaluate the impact of coriting on the duration of the procedure and the complication of the procedure. We collected our data in Policlinico Umberto Primo, and 46 patients were enrolled. As our study is a prospective randomized double-blind study, we divided our patient in a complete randomized way into two groups. Group A, patients who underwent oocyte pickup without coriting, and B, oocyte pickup with coriting. However, all patients received the same IVF protocol. We recorded our patients' demographics, and as you can see here, in both groups, the majority were due to ovulatory dysfunction. We recorded also patient age, a cycle characteristic including protocol dose, estrogen peak, and AMH values. There were no significant differences between these parameters, between these groups and these parameters. We summarized our results in this table. As you can see here, we had a significant increase in both total oocyte number and, more important, in metaphase 2 oocyte number. And in oocyte retrieval rate, we had a 14% increase in follicle coriting group compared to non-coriting group, but it was not statistically significant. On the other hand, we had significantly longer duration in the follicle coriting procedure compared to non-coriting, which was statistically significant, as you can see. However, it's worth mentioning that there were no complications associated in both procedure in these patients. So although there were more patients in the follicle coriting group, as you can see here, 25 to 21, there were no differences with respect to patient demographic, cycle characteristic, estrogen peak, as well as the number and size of follicles, which are all major factors predicting oocyte yield and maturity. In addition, there were no differences in AMH value, which is one of the most important parameters estimating ovarian reserve, which may also affect IVF outcome. So the rule of coriting in oocyte retrieval was evaluated as an additional technique capable of determining an increase in oocyte yield, which is concordant with our results in this study until now. In addition, oocyte retrieval rate was higher when coriting is performed, and it was not statistically significant, as we said, but we hypothesized that it would be due to small sample size that we have until now. So saying that there is no other techniques associated with the oocyte yield increase in the literature until now, therefore this benefit may compensate our 3 additional minutes that we had to do the coriting, especially when we demonstrated that there is no associated complication with this procedure. To conclude, follicular curettage during pickup is an additional technique that aids to increase mature oocyte yield without sacrificing oocyte quality or integrity, while it increases the length of oocyte retrieval. This increase is considered minimal. Thank you. Yes, for sure. The surgeon should now
which surgery he is going to do or which procedure. When we say double blinding, we count the patient itself, but he don't know, she doesn't know which procedure she is going to have, and the embryologist, that is the most important one, to stage and grade the whole site, and this is our results for sure. Thank you. Yeah. Especially when we are talking about couples that coming to us with the hope that they can have a children. So 3 minutes seems to be really minimal compared if we will see that it's really significantly increasing the pregnancy rate for sure, that we didn't have time to include it in our thesis till now. So it's really interesting. Thank you, professors.
Candidate is Adam Lebaum. The supervisor is Professor Fabio Santanelli. The title of the thesis is Immune Response of Pregnant Women Immunized by SARS-CoV-2.
Sorry, but it's not me the responsible for this student. I'm responsible for the next one.
I'm sorry.
Applebaum.
I'm sorry. I'm sorry.
No
So
problem.
next, I'm sorry. My mistake. So the candidate is Pembe Surel Uluchai. I apologize for that. The supervisor is Professor Isabella Quinti, and the title of the thesis is that one I said, Immune Response on Pregnant Women Immunized by SARS-CoV-2. I'm sorry about that. Please, Isabella, can you introduce the candidate?
Sure. So it was my pleasure to work with Surel, and I think she addressed, of course, a topic that is important nowadays, and is the vaccination of pregnant women to protect with SARS-CoV-2 vaccines to protect both women and newborn. But the most important thing is that she had the idea to link the results of the vaccination to the change that the pregnancy itself induces in the immune system of the women. So, of course, there are two topics together, and so she will present the data. Please, Surel.
Quinti, for your kind comments. And before my start, I'd like to thank the commission and also today I'm representing my topic about immune response of pregnant women immunized by SARS-CoV-2. I would like to start first with newborn host defense and integration of immunity between mother and newborn. Host defense of newborn is highly reliant on innate immune mechanisms and maternal passive immunity, since adaptive immunity takes some time to develop its architecture. Maternal immunity is made up of two components. First of all, it's central transfer of maternal IgG, and then maternal secretory IgA transfer via breast. Breast milk is made by lactating mammary glands, which are part of secretory immune system and reflects antigenic stimulation of mother, which is very crucial as the fetus is transferred from quasi-sterile environment into an antigenic-rich environment when it's born. And this antigenic environment usually represents the mother's antigenic environment as well. Vaccines work because they induce immunological memory, and immunological memory is the proof that the B cells are working. Immunological memory is the property of the immune system of recognizing and neutralizing a previously encountered pathogen, thereby preventing infection and disease. Our system is made up of memory B cells, which has two types, innate and germinal center derived, which represents IgM memory with innate and switched memory as germinal center innate. These types differ from each other with respect to the number of somatic mutations, origin, and developmental requirements. For example, switched memory is more differentiated form than IgM memory and requires a germinal center. We also have long-lived plasma cells, which acts as a first-line defense and produces antibody efficiently and rapidly in the face of previously encountered pathogen. We divided memory B cells with the CD27 expression, and the intensity of expression creates two subtypes. CD27 dull memory B cells, which are mostly IgM isotype, and CD27 bright memory B cells, which are more differentiated ones. Somatic mutations are lower in CD27 dull memory B cells and higher in CD27 bright memory B cells. While CD27 dull memory B cells are less mutated, they act as a precursor for the CD20 bright memory B cells and are very important in the flexibility of the immune system. Therefore, for example, in elderly, we have a domination of CD27 bright cell population, while in infants, we have CD27 dull cells domination. So our aim of the study was to determine the impact of maternal immune B cell system on immune response to SARS-CoV-2 immunization and the timing of the immune response. We had two small types of studies, B cell subset study and a pilot preliminary study. B cell subset study, we isolated B cells from peripheral blood and stained them according to their CD27 expression as well. We had 28 pregnant women and 14 age-matched control non-pregnant women. Then we measured the same values 3 months after delivery to see the difference. In a pilot preliminary study, we included 11 mothers who completed 2-dose vaccine series within the pregnancy with a recommended time frame of 3 to 4 weeks. And we took consideration the timing of vaccination as well, that we will mention later. And we measured the antibodies with a Euroimmune kit. First of our results was about changes of immune B cells during pregnancy. CD27 memory B cells are mostly lost between 2nd and 3rd trimester of pregnancy without any differentiating dull or bright. While, as we can see on the right side with our stacked bar chart, the decrease is mainly due to the loss of CD27 memory dull cells. These sequential changes should be taken into consideration when planning all maternal immunization. Then we had the second result about changes of immune B cells after pregnancy. Overall, we saw that CD27 memory B cells expand after pregnancy as the numbers thin and replenish memory B cells, so the mother do not lose its experience before. But CD27 dull memory B cells show the largest increase and therefore acts as a substrate for conversion into the CD27 bright memory B cells. First of our conclusion was that memory B cells are progressively lost after first semester. Between 2nd and 3rd trimester of pregnancy, memory B cells number expressing CD27 dull decrease specifically, and after delivery with our results, the pre-existing dull memory B cells, which are the most flexible ones, expand and maintain a repertoire cell numbers of maternal memory B cells. From our pilot preliminary study, we measured also maternal plasma anti-SARS-CoV-2 IgG antibody levels prior to vaccination, 3-4 weeks post-dose 1 and 4-8 weeks post-dose 2 to see efficiently the response to the vaccine. As we presented in this violent talk, we have an efficient response of pregnant women after post-dose 2 and also post-dose 1 relatively, as we show also the p-values comparing
pre-vaccine, post-dose 1, post-dose 1, post-dose 2, and all three of them being significant. Maternal plasma anti-SARS-CoV IgG antibody was also taken into account with the timing of the vaccinations, as we mentioned before. So in our pregnant participants, 11 pregnant participants, the second dose was given at 29 weeks for all of them, while 5 of them received their first vaccine dose in the second trimester and 6 of them in the third trimester. And overall, we found that the maternal anti-specific spike 1 specific IgG concentration in maternal sera at the time of delivery were lower in those vaccinated in second trimester than those in third trimester, which is shown with our data. So we made these conclusions that the transition of memory B cells from CD27 dull to the CD27 bright stage, which we demonstrated with our first study, do not affect the maternal immunization efficacy, as we saw an efficient response to the vaccination. We also observed that earlier gestational age at the time of vaccination was directly associated with lower maternal SARS-CoV-2 IgG levels at the term. Thank you for your attention.
Very much. I'm asking to the committee if there are questions or comments.
We just observed that in the second trimester, it had a lower efficacy. But in general, we advise that pregnant women, without any regarding to the trimester, not waiting for the third trimester, to have the vaccination as soon as possible for the benefit of the woman and also the infant.
Are you satisfied? I would be satisfied. So thank you very much.
Thank you.
Now is the turn of Adam Applebaum. The supervisor is Professor Fabio Santanelli, who is from remote, and I'm asking him if he wishes to introduce the candidate.
Yes,
Can you hear me?
yes, I do. Thank you. Sorry, I apologize to be on remote, participating on remote, but we had some problem to solve. So I'm pleased to introduce Adam. He prepared a very interesting study by itself, and it's a prospective assessment of pulmonary function after a specific type of breast reconstruction, which involves the abdominal wall, and that's a very important kind of breast reconstruction, very sophisticated. This technique pays a lot of attention to the function of the abdominal wall, which is tightly connected to the respiratory function. So I'm pleased to introduce Adam, and Adam will show us the results of this study. Thank you, Adam.
Thank you very much. Adam, you can carry on.
Good morning, everyone. Thank you, Professor Santanelli. Thank you, committee. Today, I will discuss my thesis on topic as prospective assessment of pulmonary function after immediate unilateral deep inferoepigastric perforator flap breast reconstruction. But before we going deeper in our study, let's have a brief background on what is breast reconstruction and why it's important to perform pulmonary function assessment. Knowing the fact that 1 in 8 women will develop breast cancer during her life makes breast reconstruction an integrated part in breast cancer management. Today, more individualized approach is used that based on personal preferences of the patient, primary tumor extent and characteristics, and other parameters. Our department offers all types of breast reconstruction that can be implant-based, autologous tissue-based with free flaps and pedicle flaps, and combined using both implants and autologous tissue. The deep flap considered standard in breast reconstruction. But what is it? It's type of perforated flap that harvests from lower abdomen as the adipocutaneous or adipocutaneous flap. It receives blood supply from deep inferior epigastric artery, and it has several advantages. It gives natural appearance to the newly reconstructed breast. It leaves low donor site morbidity. In addition, patient benefits from aesthetic results as in abdominoplasty, and result is permanent without need in future interventions. However, it should be mentioned that operation is technically demanding and highly depends on operator. Having just few contraindications, such as ASA score higher than 3 and blood coagulation anomalies, makes this option a preferable one in breast reconstruction. Regarding pulmonary function, the most common used test is spirometry test, and it provides us following parameters such as forced volume capacity, forced expiratory volume during first second, the ratio, and peak expiratory flow. All our deep flap candidates undergo preoperative spirometry tests in order to evaluate pulmonary function and to exclude possible contraindication for surgery. The objective of our study was comparison of preoperative and postoperative spirometry tests in patients undergoing deep flap breast reconstruction. We conducted our study in the period from June 2019 till January 2021. We included in our study 21 patients suitable for breast reconstruction with deep flap. The exclusion criteria were loss to follow-up and contraindication to deep flap. Each one of the patients underwent immediate unilateral breast reconstruction and performed spirometry test 1 month preoperatively and 1 year postoperatively. The surgical techniques that were applied can be summarized in few steps, such as perforator selection and this dissection through the rectus abdominis muscle with careful preservation of intercostal nerve, specifically in case of lateral perforators. Then transfer and rotation of the flap from donor side to recipient with subsequent anastomosis to circumflex scapular vessels. The abdominal wall was closed by layers. Rectus abdominis muscles were closed by approximation and continuous running suture. Anterior rectus sheaths were closed with interrupted horizontal suture, and we didn't perform any rectus plication muscle. In results, you can see that we had wide variability in our population with age in range from 39 to 78. This patient having some of them had a history of respiratory disorders such as COPD and asthma that were well controlled, and some of them had previous abdominal surgeries. We saw an improvement in the mean values of all 4 variables. However, only peak expiratory flow was statistically significant. We had 3 minor complications that were successfully managed by our team, and it was no report of respiratory complication. We can state that there is no study that addressed before us deep flap breast reconstruction and pulmonary function. What makes our study unique and relevant? Although the indication and the abdominal wall closure techniques in abdominoplasty are different for those in deep flap, there are some findings from previous studies that had similar outcomes to ours. In addition, some studies on abdominoplasty described earlier alterations in postoperative period, but didn't check long-term results. What we did in our study, we assessed pulmonary function 1 year postoperatively. So, in conclusion, we say that deep flap breast reconstruction does positively affect respiratory function as a result of the improvement of abdominal wall containment. And we believe that candidates for deep flap can avoid undergoing preoperative evaluation with spirometry test. Thank you for your attention.
Thank you very much, Adam. Is there anybody from the Commission who's interested to raise?
Asking the committee if there are comments or questions. And we'll just move on. Are you thinking to do something about the physical tests apart from ventilation and pulmonary function. I'm talking about, exercising, for example.
Yes, we can, for sure, we can do something, but in early postoperative period, it is some limitations for sure during first months because of the intervention itself. But we believe that in long term, it doesn't affect negatively, but for sure we can think about some tests that can be applied.
Okay. Thank you very much. Is Fabio Santanelli satisfied from there, from remote?
Yes, I am very satisfied. If you mean, if you meant with your question about the function of the abdominal muscle after the surgery, if I got it right, the question, then with this procedure.
Exactly what I wanted to ask.
Yes, and then with this procedure, the function of the muscle has been described that is preserved, and so there is no functional loss, and so there is no problem with it. Thank you. Very satisfied.
Thank you very much for your implementation. Thanks,
Thank you.
Adam. Candidate is Shiv Bergman. The supervisor is Professor Leopoldo Spadea. The title of the thesis is Visual Performances of a New Extended Depth of Focus Intraocular Lens with a Refractive Design, a prospective study after bilateral implantation. Please, Leopoldo, can you introduce the candidate?
Thank you, Mr. President. Cataract is the leading cause of treatable blindness in the world, affecting the 50% of people over 65 years of age and 90% over 75 years of age. Therefore, cataract surgery is the most practiced surgery in the world. Every year, 26 million of cases. Cataract procedure is consists in two phases. The first one, therapeutic, and with the opaque lens is removed. And the second one, rehabilitative, where an intraocular lens is implanted in the eye to restore good vision. Here, the candidate will talk about a new intraocular lens that we tested in our eye clinic at Polyclinic of Berkeley. Please.
Thank you, Professor, for introduction. Thank you for the committee. So, as the professor said, my thesis is about the bilateral implantation of new extended depth of focus intraocular lens. Okay, so what is cataract? Cataract is defined as an opacity within the clear lens inside the eye that reduces the amount of incoming lights and results in deterioration of the vision and breakdown of the lens microarchitecture. As you can see in the photo, when there is the opaque lens and the difference in the oncoming light with a normal lens. Different epidemiology and risk factor can cause cataract. There are different morphological classifications such as capsular cataract, cortical cataract, nuclear cataract, and polar cataract. So the different etiological classification, different reasons that can cause cataract can be congenital, development cataract, toxic cataract, senile cataract, which is the most common and frequent, traumatic cataract, complicated cataract, metabolic and electric cataract. You can see in the photo the different types. The research purpose. So the aim of the present study was to evaluate the visual outcome of a new extended depth focus intraocular lens with bilateral implantation, which means in both eyes, the new lens was implanted. A qualitative and quantitative analysis was performed, and the data were compared with those given by other studies regarding other lenses. Of the contrast sensitivity were evaluated preoperatively and after 6 months follow-up. The The surgical technique was fecal emulsification with a 2.4 millimeter clear incision in the cornea and the capsular bag implantation of the intraocular lens. 2 questionnaires were administered for this purpose to the patient to evaluate the results. So the patient experience questionnaire, as seen in the photo, summarizes the main outcomes. And additionally, all patients stated that their vision met or exceeded their expectations. The results. So a value of 20/20 achieved in 36 patients, in 36 eyes, which is around 90% of the patients. Patients that were very satisfied or satisfied with their vision was 90% after 6 months follow-up. This confirmed the successfully restoration of distant visual function, and 95% of the patients reported after 6 months not wearing any correction for distance vision, and for near vision, the percentages was around 70%. None of the patients complained about any other phenomena such as halos and glares. The conclusion. So the extended depth of focus intraocular lens of EVOLVE is a promising tool for producing excellent visual rehabilitation. It seems to provide an effective alternative to patients who desire spectacle-free lifestyle postoperatively. These lenses can supply satisfactory distance, intermediate, and near vision, and retain a good contrast sensitivity as we tested in the study, with most patients reporting about excellent satisfaction. Thank you very much for your attention.
Sure. Ask you if there are questions or comments. A comment from the hall.
Okay, so no serious complications were seen during the surgery on the postoperative time. Events such as cystoid macular edema were resolved after 2 weeks with the use of anti-inflammatory medication and therapy. No glistening and no explants were seen that caused any other optical difficulties. So in general, the intraocular lens are very good, refractive in the use of distance vision, and in general, the purpose of the study didn't show any significant or serious complication.
Much a little question for both of us. Is your center policy to change both the lens in the meantime? Because I know that there is, so it's a double operation. Okay, thank you very much. Okay, thank you.
Thank you.
The supervisor is Professor Lorenzo Tarzitani. Of the thesis is examining the psychopathology of migrants using a dimensional approach. Please, Lorenzo, can you introduce the
Thank you, Mr. President. Stylianos attended our outpatient service for migrants, and he worked on a project about a dimensional approach to psychopathology, which is addressing a serious challenge in the diagnosis and treatment of patients from other countries. And he compared in a matched sample some psychopathological dimensions with matched native patients. Thank you. Go ahead.
Thank you, Professor. So migration is a very meaningful life event that carries a higher risk for mental disorders. This is due to pre-migratory variables, such as social and environmental circumstances, early life events, and genetics, migratory variables, especially in the case of forced migration, or if migration is associated with traumatic events, and post-migratory variables, such as transcultural stress, discrimination, and lack of social support. Unfortunately, the diagnostic tools developed in Western countries are often incapable of detecting specific aspects and symptoms of psychological problems in individuals who grew up in different cultural contexts. This leads to a tendency to misdiagnose and to overuse the not otherwise specified designation in migrant patients who show blurred symptomatology. These shortcomings create the need for the utilization of a dimensional approach, which is an approach that does not focus on diagnostic categories, but on quantitative symptom dimensions. And what we mean by dimensions is clusters of related psychological and behavioral characteristics which occur together. Sadly, research into a dimensional perspective on migrants' mental health is currently very scant, which raises the need for this study. The aim of the study was to examine the psychopathology in a sample of migrants who suffer from a mental disorder using the dimensional approach, and then compare the results to a control group of Italian natives who were matched for gender, categorical diagnosis, severity of the diagnosis, and age. So 112 migrants were followed in the migration psychiatry outpatient service of the Policlinico Umberto I, and 112 native controls were also recruited and followed. All of the patients were diagnosed based on the DSM-4 criteria, with the most frequent diagnosis being not otherwise specified, which underlines the classification uncertainty of the symptomatology. The migrants were also administered an ad hoc questionnaire for the collection of the pre-migratory, migratory, and post-migratory variables, and the expanded version of the brief psychiatric rating scale was used to assess symptom severity. The dimensional evaluation of the patient's psychopathology was performed using the SVARAD, which is an acronym for the Italian name Scala per la Valutazione Rapida Dimensionale. This is a quick and easy to use tool that has shown psychometric characteristics in clinical settings similar to those of the study. It is a hetero-administered scale, which means that the examiner rates each of these 10 items shown here from 0, that is absent, to 4, that is extreme, and then the individual scores are added together, and an overall score is obtained with a possible maximum of 40. The SVARAD dimensional approach showed higher scores in somatization and lower scores in activation and obsessiveness in migrant patients compared to native patients. This outlines an internalizing profile for the migrant group compared to the native one. Furthermore, the scores of impulsivity and aggressiveness were lower in female migrants compared to male migrants. With respect to the other items, no significant differences were found. A correlation analysis was conducted between the SVARAD items, which highlighted a positive correlation between the items of anger or aggressiveness and activation, and between impulsivity and activation. A negative correlation was noted between the items of sadness or demoralization and activation, and anger or aggressiveness and somatization. The results are most likely due to two main reasons. The first being the language skills, because only some of the patients spoke fluent Italian, with the remaining either communicating in another language that the operators could also speak, such as English or French, or requiring the presence of a linguistic mediator in order to adequately communicate. The second reason is the cultural root of the sample. That is, migrant patients originated from non-Western countries, as is shown on the slide, and these countries tend to show higher somatization than Western ones. This is theorized to be due to the more collectivist nature of these societies that, unlike Western societies, tend to value social cohesion more than individual expression, and may discourage externalization as a form of detachment from the society, which in turn leads to individuals internalizing their distress, and it increases the risk for somatization. Somatization should be thought of not as a symptom leading to a specific DSM diagnosis, but as a way for the patient to express and communicate their mental suffering. This raises the need for a dimensional approach, and so does the fact that somatization is highly heterogeneous in its presentation, which means that it cannot be adequately expressed through the strict confines of categorical approaches. We can therefore conclude that the use of dimensional approaches in conjunction with categorical approaches can assist in elucidating the polymorphic nature of the patient's psychopathology and can help us understand the more peculiar expression of migrant patients' mental suffering. Thank you. That is a good question, but I didn't mention it here. But one of the exclusion criteria was patients younger than 18 years old. So this was specifically in adults.
The supervisor is Professor Roberto Cangemi. The title of the thesis is Short-Term Cardiovascular Events and Endotoxemia in Patients Hospitalized for Community-Acquired Pneumonia.
Good morning. Good morning, everybody. It is a pleasure. Madeleine helped me with studies in these last few years, most of them involved with COVID-19, but and she worked with a lot of. However, in the end, she asked, please, I don't want to link my thesis to COVID. So we decided to retrospectively analyze both of patients with the community-acquired pneumonia. Community-acquired pneumonia is still one of the most important causes of death for infectious disease. There are some things that we know. For example, it is linked to cardiovascular disease, risk of cardiovascular disease. And what is less known is that, for example, during pneumonia, there is an increase of plasma levels of LPS. We still don't know why. And I presented a few days ago another student talking about the effect, the long-term mortality. In this case, we, on the contrary, focused on short-term cardiovascular trend, hospitalization, and LPS.
Thank you, Professor Cangemi. So a little background, community-acquired pneumonia is part of the lower respiratory tract infection, and according to the WHO, this is still the 14th leading cause of mortality worldwide in 2019. It has an incidence of 1.5 to 1.7 in 1,000 in Europe, and a mortality between 1% in outpatients and over 40% in intensive care patients. The etiology remains unknown in most of the cases, but other potential causes are bacteria. Here, most commonly found are Streptococcus pneumonia and rarely gram-negative bacteria and viruses. There has been an association between community-acquired pneumonia and cardiovascular events. Our recent meta-analysis showed that it's observed in about 14% of patients and up to 30% of hospitalized patients with an increasing risk for early mortality. These events include new or worsening heart failure, arrhythmias, acute coronary syndrome, including myocardial infarction and unstable angina, and also cerebrovascular events with TIA and strokes. The highest incidence of these cardiac complications is found in the first 30 days of the infection, and with about 50% in the first 24 hours and 90% in 7 days. The exact pathophysiology is unknown, but various factors contribute to the occurrence of cardiovascular events, among which we find the relative hypoxemia, the direct infection of the myocardium and pericardium, and the systemic inflammatory response causing endothelial dysfunction. Also, pre-existing plaques that might become unstable or rupture can attribute to that, and a proglobin site. LPS might attribute to this proglobin site. It's also called the lipopolysaccharide or endotoxin, and is the primary component of the outer membrane of gram-negative bacteria. Once, if they're shed off the bacteria and enter the human bloodstream, they can attach to the major receptor, the toll-like receptor 4, which is found on several immune cells, including innate immune cells and platelets. It elicits a very strong immune response and the release of pro-inflammatory cytokines, acute phase proteins, and reactive oxygen species. It can also directly trigger the cognitive pathway of the complement system, causing an activation of the coagulation cascade. Furthermore, platelets stimulated by LPS release their granules containing cytokines, P-selectin, and CD40 ligand. All of this leads to the expression of tissue factors, the formation of neutrophil, extracellular traps, the aggregation of platelets, and the formation of thrombi, eventually causing cardiovascular events. So where is this LPS coming from? As I initially said, community-acquired pneumonia is rarely caused by gram-negative bacteria, though gram-negative bacteria are abundantly found in the intestinal microbiota. Usually the intestinal barrier is formed by enterocytes sealed by tight junctions. These tight junctions, though, might be modulated by the protein zonulin. Zonulin dislocates zonular occludens, which leads to an opening of the tight junctions, which could allow the entering of LPS from the intestinal lumen. We can measure zonulin in the blood plasma and use it as a biomarker for intestinal permeability. Other factors affecting the intestinal barrier are inflammatory cytokines, aging, stress, physical activity, and specific drugs. So the aim of our study was to evaluate LPS plasma level in patients hospitalized with community-acquired pneumonia, analysis of a relationship between LPS and the cardiovascular risk during hospitalization, and the assessment of intestinal hyperpermeability via the measuring of zonulin. We included 266 adult patients, and the baseline assessment included analysis comorbidities, the assessment via the pulmonary severity index at 12-week ECG, routine blood work, high sensitivity cardiac troponin, and an echocardiogram. We measured in all patients the serum, LPS, and zonulin levels at admission and discharge via the ELISA method. We considered the outcomes of major cardiovascular events, including myocardial infarction and stroke. So the results show that in all patients, we had a rise in LPS plasma levels that decreased with discharge, as you can see in the first panel. These LPL levels were correlated to zonulin that you can see in the second panel. Furthermore, we observed in 32 patients a major cardiovascular event with 29 non-ST elevation myocardial infarctions and 3 strokes during hospitalization with an average stay of 10 days. These patients generally were of older age, were more likely to have hypertension, a history of coronary heart disease, and chronic atrial fibrillation. They were also had higher PSI scores and risk classification. Dividing the LPS concentrations into quartiles, we also observed an increase with the progression in the cardiovascular events, as you can see in the second panel. And the LPL levels were generally higher in patients experiencing the cardiovascular events, as you can see in the first chart. So we can deduce from this data that community-acquired pneumonia is associated to a rise in LPS levels, which potentially originate from the intestinal microbiota. LPS might be a trigger for cardiovascular events, and these findings could potentially help us in further therapeutic approaches, which might be the measuring of LPS as a predictive marker for cardiovascular events, the use of specific antibiotics or probiotics to modify the intestinal microbiota, or drugs modulating the intestinal barrier. But further studies are needed to confirm the origin of LPS and potentially analyze other factors contributing to these findings.
Thank you very much. Again, there are questions or comments? A couple.
So it hasn't been tried yet in community-acquired pneumonia, but it has been observed that in Crohn's disease patients, steroids can increase or like decrease the hyperpermeability, and this is thought majorly through the anti-inflammatory aspect of the corticosteroids.
Very much. There is another question.
Unfortunately, our study was yet very small size, so we didn't focus on that aspect.
Thank you very much. I'm satisfied with that. With Nada Barak, the supervisor is Professor Vito Campisani. The title of the thesis is US elastography with different techniques for thyroid nodule characterization, systematic review, and meta-analysis. Please, Vito, can you introduce the candidate?
Thanks, Mr. President. Thanks, Fabio. Good morning to everybody. It's really my pleasure to introduce Nadav, who actively contributed to this meta-analysis, whose aim was to try to address what is the most effective ultrasound elastography techniques. In what? Entire nodal characterization. Some years ago, ultrasound was considered the Cinderella of imaging modalities. Right now, thanking also to our contribution, is considered an effective new technique, including really ultrasound elastography, that can provide us the possibility to discriminate if a nodule is soft or stiff. But however, hot issue is still under debate. This is one of them, and I hope that Nada will show you relevant results. It was recently published in very high impact factor journal, gained also already in 2 months for citation, trying to address this hot issue. Please, Nada.
Professor Cantisani, thank you, Mr. President, and thank you, committee and everyone for coming. So this systematic review and meta-analysis was published in March. As the professor said, it's very recent information. Some background about thyroid nodules. As you may or may not know, it is very common in the population, and as autopsies confirm, it increases the prevalence with age. And for the case of microcarcinomas, which are less than 2 centimeters, there has been an increase in past years, which is considered to be due to the increasing abilities of diagnostic performances, which is why we think overdiagnosis could lead to the overtreatment. And overtreatment could be crucial for the patient with a big burden and also a burden on the healthcare system. To address that, fine needle aspiration is taken from the nodule itself and cytologically analyzed. But this is a mini invasive technique, and we can confront that using the basic beam mode ultrasound. Now, the basic beam mode ultrasound has moderate to high accuracy, and as suggested by several guidelines, this is example for American Thyroid Association, with increasing from bottom to top, as you can see, for benign, for example, completely cystic or spongiform, to high suspicion for malignancy, which could be microcalcifications, irregular margins. Information that we need to determine whether the nodule is benign or malignant. So we use something called the reporting system lexicon, the THYREDS. The thyroid system is not currently routinely used in clinical practice, and as you can see, there are many of them used by different clinical scenarios, and it is not sure, there's no consensus as to which one is the best yet. For this reason, we can use elastography as a supplementary technology, which allows us to understand how stiff or hard the tissue is, which could occur in different cases, as in the case of microenvironment of the tumor, where collagen deposits irregularly within the extracellular matrix and the tissue stiff. Now, this could be done by one of two techniques, one of which is the strain elastography, which uses quasi-static forces that are sent either by externally with the probe itself by the examiner or internally by the carotid pulsation. And the probe picks up the minute deformities in length between the compressed and the uncompressed state. Another possibility is sending the acoustic radiation impulses by the probe itself again. And like throwing a stone in water, the ripples that form around it, the wave propagates in the tissue, and the probe picks up the speed of the wave and allows, through calculation, to tell us how stiff or elastic the tissue is. Elastography in the guidelines for the diagnostic workup of thyroid nodules. PubMed and MBase were screened for studies between 2011 and 2021. Only clinical studies that involved human subjects were included, and only if they compared it to the appropriate gold standard. They were excluded if they didn't include more than 50 nodules to try to decrease the outliers, and if they focused on a specific population, like for the example of final aspiration results, which could be indeterminate or undiagnostic, for the purpose of trying to combat the heterogeneity of those studies. 72 reports were included eventually, and they sometimes used one technique or more than one technique, which adds up to 80 database to confirm from. Now, these are the results for the 3 different main techniques. I only mentioned 2 of them in the techniques, but you will see what semi-quantitative means. Qualitative is, as I said, the strain, which gives us the output in a color map, which we use to say if the tissue is hard or not. Semi-quantitative is the same strain, but then a region of interest is taken from the nodule itself and the healthy parenchyma and allows us a number output ratio. So it's semi-quantitative. While the quantitative is the shear wave, which provides us output in either meters per second or converts to the kilopascal to determine how hard the tissue is. In terms of sensitivity and specificity, all 3 techniques showed quite good accuracy, around 80, and it is either similar or higher to the beam mode ultrasound, while the positive likelihood ratio in this case, between 2 to 5, we can say that there's some significance in order to determine whether a positive test relies a positive actual malignant nodule, while to determine the diagnostic performance of the test, while area under the curve is a summary line, which allows us to take into consideration a trade-off between the sensitivity and one minus the specificity. And different models could be used. In this meta-analysis, the Moses-et-al was used. And as you can see, the semi-quantitative had a area under the curve of 93% with confidence interval all over 90. And also a statistical analysis was confronted for all 3 techniques, one against the other, and only semi-quantitative against quantitative was shown to be significant with a p-value of 0.01. Limitations to the study, which were quite many, primarily the potential selection bias. The nodules in the study were about 33% malignant eventually on the gold standard, while in the general population it's around 10%. Which is thought to be also due to the fact that the patient were sent to the high-level centers to be diagnosed by the elastography. many histological patterns, because, for example, follicular carcinoma doesn't necessarily have to behave in a manner that makes it as stiff as papillary carcinoma. Different thresholds, due to the fact that some studies included in the meta-analysis predefine the threshold, while others use the calculations to determine which would be the best threshold to make this confrontation. And currently in the market, there are many companies that use many different instruments and equipment, so it varies. So it's actually an umbrella term to say that there are only 3 techniques used. In conclusion, the qualitative, semi-quantitative, and qualitative elastography techniques are accurate in differentiating suspicious thyroid nodules from benign thyroid nodules, with a slight better performance, as I showed, by the means of semi-quantitative elastography strain ratio. However, some studies of a larger magnitude were also showing that the qualitative could be better, and that the ultrasound elastography should be incorporated into the workup algorithm for thyroid nodule classification, has to be defined by experts who write guidelines, at least one of which stands with us today. Thank you very much.
Questions or comments? One from Nito.
So, of course, if the baseline ultrasonography with all the different malignancy high suspicious features are positive and the tissue is not shown to be hard, we couldn't exclude malignancy due to those high suspicion level malignancy. We could sometimes do the opposite in the case that elastography is positive, but we have no other markers, to decide that in this patient we don't want follow-up, but we want to proceed with the full diagnostic workup for malignancy.
Thank you very much. I think Ambra Taglietti, the supervisor is no, Celeste Gabriele, I'm sorry, again. The candidate is Gabriele Celeste. The supervisor is Professoressa Maria Rosa Ciardi. There is also a co-supervisor.
Yes, it's my pleasure just to introduce the supervisor, the co-supervisors, Professor Sabatini, who strictly followed Gabriele in his thesis, focusing on
Thank you, Maria. Today we are discussing the program of Medicina Generale. You can see, every one of us can see how the pandemic is changing daily, how the increasing of the case is modifying our way of life, especially in the relationship between medical practitioner, general practitioner, and the patients, and most of all in the risk of burnout. So let me introduce to you Gabriele, that has been working that you will appreciate his analysis and his results. So
good morning. Thank you, my supervisor and co-supervisor, for the gentle introduction. Thank you, President, and the entire Commission. So the COVID-19 pandemic appeared suddenly and in a controlled manner, and many efforts were required by all health professionals. General practitioners have also been called to give a strong contribution. In Lazio, in 2019, there were around 30,000 contacts with the patient, and after 1 year, this values have risen to 40,000. On the 30th January 2022, the total number of home isolation patients was almost 289,000. The infection containment provision have revolutionized the relationship between doctor and patient, forcing both to interact with the use of telecommunication. The increased bureaucracy has led to a general fatigue in doctors, with the risk of developing the burnout syndrome. that is a persistent and gradual psychophysical decline in response to chronic stress job-related. Norma is affecting the health professions that are always in contact with the public. And so it's really common to find health sector as well. We want to investigate if during the pandemic period, the practitioner has some discomfort by using telecommunication, and whether the experience gained in this area will lead to its use in the future. We want also to study the interest perceived by patients in telecommunication. And finally, we want to evaluate the burnout level according to emotional exhaustion, depersonalization, and reduced personal completion. The study respected the confidentiality of participants was performed by using Google Forms for the general practitioner. 52 were from the municipality of Rome and 52 were from the municipality of Messina. A paper questionnaire was used for patient. 111 were the participants, 53 from a medical clinic in Rome, and 58 they belong to a medical clinic in Messina. The muscle questionnaire was used to evaluate the severity of burnout level. So in the survey that was carried out in the general practitioner, 91 preferred that they use instant messaging application, and just 15 referred to them. 86 report benefit from using instant messaging application, and 18 assessed the opposite. 93 are oriented to the future use of technological equipment, and just 11 not interested in such a device. And finally, 73 report an improvement in the workload against 51. The burnout assessment referred that the participant had to refer the frequency according to a scale, ranging from 0, correspond to never, to 6, correspond to every day. The test consists in 22 questions. 9 of them gave information about the emotional exhaustion, and the one that received the high average score was I feel emotionally exhausted because of my work. Then 5 questions were regarding the personalization aspect, and the one that received the high average score was I get the feeling that I worked hard. And lastly, the question about personal accomplishment, 8 in total, and the one that received the lower average score was I feel that the influence of the people positive for my work. As you can observe in the graphs, these are the high level in the emotional exhaustion and the personalization reduced personal accomplishment among the general practitioners. The burnout was also analyzing according to age of doctor, their family unit, and the number of patients, showing no substantial difference according to the 3 groups. The patients survived, the majority represented by 61 participants, had a good knowledge of communication before the pandemic period. Then 77 had a perception benefit related to the use of instant messaging application, and 77 were not suffering from the lack of face-to-face visits. So the COVID-19 pandemic was an input for general practitioners, they made use, and also they are well inclined to use in the future. And the patient also appreciate the advantages, such as no crowd in the waiting room and less discomfort due to travel. Most patients were not suffering from the lack of face-to-face visit that was compensated quite effectively by telecommunication. However, the study indicated high level of burnout among doctors. So further investigation needed to understand if there is a correlation with the pandemic plan. So we can conclude by saying that the majority of health professionals and patients have a quite considerable experience in the field of telemedicine, and therefore it should be improved in order to promote the most practice. Thank you for having me.
I'm asking if there are questions or comments. That's one. I saw that you got the results from 2 different regions.
Yes.
Was any difference between the 2 regions?
No, actually, there are high level in both situations, both in Sicily and in Italy.
It was the same. There was no difference
all are
between
suffering.
doctors and
Yeah,
patients.
all are suffering from the burnout.
Okay, thank you very much. Next candidate is Ambra Taglietti, supervisor, again, la professoressa Maria Rosa Ciardi. The title of the thesis is Markers of B lymphocytes activation and their association with the infectious risk in ocrelizumab treated multiple sclerosis patients. Ms. Maria Rosa, can you introduce the candidate?
Good morning to the Mr. President, to the audience all. Ambra is attending our lab since 19. And during this time, she focused on many topics, and for his thesis she treated about the patient treated with a modified disease-modifying therapy on some cytokine before and during treatment. And now she will show you the data.
Good morning, everyone, and thank you, Professor, for your introduction. Thank you, committee and Mr. President. Multiple sclerosis is a chronic demyelinating condition of the central nervous system, and the increasing understanding of its underlying pathological mechanism has led to the introduction of innovative disease-modifying therapies, or DMTs, which have immunomodulating and immunosuppressing properties and traditionally target the T-cell compartment of the immune system. However, despite their great efficacy, these drugs may expose our patients to a higher infectious risk from either latent or de novo pathogens. Ocrelizumab is one of the most recently introduced DMTs, and as an anti-CD20 monoclonal antibody, it induces a profound and rapid B-cell depletion. It is administered as an infusion every 6 months, and the use of anti-CD20 therapies, including rituximab and ocrelizumab, has highlighted the role of B cells in the immunopathogenesis of MS. In fact, B cells may develop a self-reactive phenotype, which is then sustained and promoted by cytokines such as BAFF, B-cell activating factor, which is needed for the survival of B cells, APRIL, a proliferating factor, which stimulates antigen-experienced B cells, and CD40 ligand, which is necessary for the clonal expansion within the germinal centers. The aims of our study were first to define and address the infectious risk in MS patients undergoing various DMT regimens, whereas secondary objectives included the longitudinal evaluations of B-cell cytokines during ocrelizumab treatment and their evaluation in association with the development of infectious events. The infectious risk of our MS patient was evaluated according to a 2-level screening tool. All patients underwent first-level screening to identify active or latent infectious diseases. And in case of positive results, the patients underwent second-level screening with individualized approaches for their specific cases. The infectious risk was regularly reassessed prior to DMT initiation, DMT switch, and during ongoing treatment with 6-month intervals for injectable DMTs and 12-month intervals for oral DMTs. Moreover, to evaluate the plasma levels of our B-cell cytokines in an ocrelizumab-treated subgroup of MS patients, full blood samples were withdrawn at 3 time points according to the drug infusion schedule, whereas we obtained a single sample from healthy donors. The B-cell markers were assessed by multiplex flow cytometry, and we then stratified our ocrelizumab-treated patients according to the development of infectious events into 2 groups, a group with infectious complications and a group without them. In this study, we were able to 174 MS patients that were referred to the neuroinfectious unit of our hospital. In this table, you can see their clinical characteristics. And interesting enough, of these patients, 71 had ocrelizumab as their current or prospective treatment. All 174 MS patients underwent first-level infectious risk assessment to identify infections. And as we can see, 42 of them had either positive or indeterminate results on first level. In particular, the infections that we identified were hepatitis B, hepatitis C, and tuberculosis. These 42 patients then underwent individualized second-level testing, which allowed us to diagnose 18 patients with latent hepatitis B infection, 4 patients with past hepatitis C infection, 17 patients with latent tuberculosis, 2 patients with active tuberculosis, and at last, the 3 patients that first had indeterminate results on first-level screening were retested after 2 or 3 weeks for tuberculosis and tested negative. Then, out of the 71 MS patients that were referred for current or prospective ocrelizumab treatment, 38 of them underwent regularly scheduled ocrelizumab infusions and were then followed up over a period of 12 months. During this period, 14 of these patients developed infectious events, which included 2 reactivations of herpes simplex virus 1, 5 respiratory tract infections, and 9 recurrent urinary tract infections. The evaluations of the B cell cytokines was then performed in our 38 ocrelizumab-treated patients and in 26 age and sex matched healthy donors. We can see that at baseline, the cytokine levels of MS patients were significantly higher before ocrelizumab treatment in our MS population compared to the healthy donors. Then on longitudinal evaluations, we can see the changes during ocrelizumab treatment. In particular, BAF undergoes significant increase throughout treatment and it's significant at all time points, whereas opposite trends can be seen for APRIL and CD40 ligand. For APRIL, we can see significant reductions between T0 and T12 and T6 and T12. Similarly, CD40 ligand, the significance between T0 and T12 and T6 and T12, with the values of CD40 ligand yet significantly higher at T0 and T6 compared to the healthy donors. Moreover, we were able to observe a positive correlation between the immunoglobulin G levels of our patients and their values of APRIL and CD40 ligand at baseline before ocrelizumab treatment. And finally, upon the stratification of our patients into the two groups regarding infectious complications, we were able to assess the B-cell markers across these two groups. We observed that BAF was significantly higher and remained significantly higher throughout treatment in the group of patients that experienced infectious complications compared to their counterparts, whereas no significant variations can be seen in APRIL and CD40 ligand across these two groups. Hence, this study confirms the validity of periodic infectious risk evaluation in MS patients as a useful tool to identify high-risk patients, probably manage de novo or de novo infections or reactivations, and most importantly, avoid delays or discontinuations in their DMT regimens. One of the limitations of this study is certainly the multitude of treatments of DMTs that our population was undergoing, which didn't allow us to get any insight on DMT-specific infectious risk. In MS patients, we also observed a baseline immune dysregulations in their B-cell cytokines, and ongoing anti-CD20 therapy may further induce dynamic changes with significant increases in BAF and APRIL CD40 ligand showing opposite trends. These findings are in conformity and consistent with previous findings, previous reports regarding rituximab use for autoimmune conditions. However, considering the significant elevations in BAF that we observed in those vulnerable patients that experienced infectious events during the course of ocrelizumab, we may consider BAF a marker of immune dysfunction, which could have a predictive role over the risk of infectious complication in this population. Thank you. In the trials that were performed to then approve ocrelizumab from either relapsing remitting multiple sclerosis or primary progressive multiple sclerosis, thrombosis was not a significant side effect of this drug. Most significant ones were injection site related infections and or irritation and complications, and then systemic infections. Those were the main ones. Thank you.
Okay, thank you, Mr. President. I am very glad to introduce Matt, who actively attended our outpatient heart failure service in the last months. Today we'll present data on the syndrome of heart failure. We will listen the impressive epidemiology of this syndrome, and in particular on our new HLM classification of heart failure in comparison with the other classifications.
Good morning, everyone. Thank you, Professor, for the presentation. Thank you to the Commission and thank you to the President. So, heart failure is a life-threatening multi-complex syndrome that is caused by a structural or functional impairment of ventricular filling or ejection, which as a result leads to decreased capacity of the heart to provide the body's metabolic requirements. The estimated prevalence of heart failure is high, especially in older population. Indeed, it is the most common cause of hospitalization above 65 years old. From epidemiological point of view, we can consider heart failure as the non-transmissible pandemic of the new millennium, because as the prevalence is increasing, also the direct and indirect costs are increasing together with increased rate of hospitalization and mortality. If you look at the lower left picture, left corner picture, the main problem of heart failure is summarized here. The main problem with heart failure is the hospitalization rate. The probability of rehospitalization within 12 months from the previous hospitalization is really high. And at some point, these patients reach a viscous cycle and they keep rehospitalizing and unfortunately eventually die. If you look on the graphs on the right lower corner, you can see that heart failure has higher mortality than most type of cancers. The only cancer that has higher mortality rate than heart failure is the lung cancer. Heart failure is a systemic clinical syndrome which starts at the heart, but throughout its progression starts involving peripheral organs and lead to malfunction of peripheral organs and death. In this sense, we can actually compare it to cancer, because if you think about cancer, it also starts as a primary neoplastic mass, which during its progression starts involving other organs as well. When we compare the management of the two conditions, if we look at the TNM classification, which is the most commonly used classification for cancer, it guides us through the management of cancer according to the progression of the disease, independently by the symptoms. Whereas, if you look at the classifications used by the European Society of Cardiology, American College of Cardiology, and American Heart Association, the classifications used by these societies are mainly based on symptoms such as the New York Heart Association classification and left ventricular ejection fraction. These classifications has a lot of limitations. First of all, if we take into consideration symptoms, symptoms has large inter-individual variability in the interpretation of the severity, and it is not heart failure specific. Whereas left ventricular ejection fraction is a simple categorical cardiocentric view, which completely disregards the pathophysiological mechanism and the etiology behind heart failure. Shortly, we can say that heart failure is the cancer for the heart. The more it progresses, the more its complexity progresses. Here you can see the correlation between the TNM classification and the HLM classification that we proposed. H stands for the heart, which is in analogy with the primary tumor mass. Lung, being the closest organ to the heart, is in analogy with lymph nodes. And reminding ourselves from the etymological meaning of metastasis, from ancient Greek, which means displacement, is in analogy with the malfunction of other organs. The aim of our study was to compare the HLM score prognostic performance with the main current heart failure classifications in predicting the composite endpoint of all-cause death and rehospitalization at 12 months follow-up. In total, 1,720 patients were enrolled and followed up for 12 months. Here you can see that in HLM classification, we allocated 4 levels of severity to each parameter, from 0 to 3. If we look at H parameter, we can see that H0 stands for systolic or diastolic dysfunction in the absence of structural cardiac damage. H1, dysfunction with structural damage, however, without left ventricular dilation, and H2, systolic or diastolic dysfunction, both with structural damage and left ventricular dilation, whereas H3 refers to biventricular systolic dysfunction. On the other hand, if we look at the L parameter, L0 refers to absence of any lung involvement, L1, hemodynamic lung involvement without clinical signs of lung congestion, L2, together with clinical signs of lung congestion, and L3 stands for cardiac lung defined by arterialization of the pulmonary vasculature with post-capillary hypertension. On the other hand, the M parameter, M parameter was classified according to the number of organs involved. So no organ involvement, one systemic organ involvement, two systemic organ damage, or three or more. Here you can see the cutoffs and the instruments that we have used to define the malfunction of the peripheral organs. And here are our results. You can see the baseline features of our patients. And by the end of 12 months, we stratified each patient according to HLM, NYAH, ACC, HAA, and left ventricular ejection fraction classifications. You can see how we can calculate a specific HLM score for each patient by using the HLM parameters. So H parameter multiplied by 2 plus L parameter multiplied by 3 plus M parameter multiplied by 1. And each score range is allocated a specific HLM stage. So when we compare the HLM score with other classification, as you can see from this row curve, the area under the curve was largest for HLM, which shows that out of all this classification, it had the best overall good accuracy. And here in the Kaplan-Meier graphs, you can see that HLM was more powerful in differentiating between each stages of patients, because if you look at all the other classifications, they are more overlapping, whereas HLM is more accurate and more specific at differentiating different stages. Therefore, what we concluded is that the cardiocentric view of heart failure based on symptoms and left ventricular ejection fraction is not adequate to stratify heart failure patients in terms of prognosis. HLM allows us to perform a more accurate anatomofunctional evaluation of heart failure patients by using a comprehensive and pathophysiological approach. HLM identifies the true high-risk patient, differentiating advanced and end-stage heart failure patients. This is really important because if we think about the management of advanced and end-stage heart failure patients, advanced heart failure patients have the most expensive therapies, whereas the main goal of end-stage heart failure is to increase quality of life of our patients. Therefore, HLM helps us to choose the right patient for the right treatment at the right time, therefore also providing us economic and ethic appropriateness. We also created an interactive mobile app that will always be available for each physician to calculate HLM score whenever they need it. Thank you for your attention.
Much. Asking to the public if there are questions or comments. I have one. So as you know, in cancer, if you have a metastasis, usually it is a contraindication for transplant. Can you use your classification if you have M positive as a contraindication for a heart transplant, you think? It's for both of us.
Okay. We actually didn't study if there will be a contraindication for the heart transplantation, because the most powerful point of HLM is to differentiate between advanced stage heart failure and end stage. And the best treatments for advanced stage heart failure is ventricular assisted therapy or heart transplantation. So yes, so HLM actually helps us to find the patients who need heart transplantation, I would say.
and implementation? How?
Just one more information. The M parameter, the malfunction of other organ, differently from PNM, doesn't correlate with a poor prognosis, since the point of our metastasis is just one. So actually, the most important point is L, the lung involvement. Of course, we don't eliminate the indication for heart transplantation if we have a malfunction of other organs. So in this sense, different from PNM.
Okay. Thank you very much. The supervisor is Professor Franco. The title of the thesis is lymphocyte immunoprofiling in non-muscle invasive bladder cancer patients during Bacillus calmette-guerin intravesical therapy. I know that there is also a co-supervisor who is called Francesca De Rosa, so I'm asking Giorgio to introduce the candidate, and then we can ask Francesca De Rosa to say two words.
Ladies and gentlemen, good morning to everybody. First of all, I wish to acknowledge and thank Professor De Rosa for her tremendous job carrying out this thesis. She works at the CNF, she's professor there, and she did all the heaviest part of this thesis, all the lab and immunologic testing. So thank you very much, Francesca. Say a few words to introduce the thesis. As far as we urologists are concerned, I just want to say that for us, it's very important, the aim of the thesis that Alexandru Ciucă carried out excellently, I would say, in the last months, because non-muscle invasive or superficial bladder cancer is very, very prevalent, and the mainstay of the treatment is BCG instillation into the bladder. So to have a tool to discriminate which patient may benefit from this treatment or not, it's really important for us. So please, Francesca, you want to say introduction? Thank you very much.
Franco, it's a pleasure to introduce Alexandru Ciucă. He worked a lot on this project that was started when Alexandru joined the lab. So he took care of everything from the clinical side, the ethical committee, the collection of the blood sample, interaction with the patients, and on our side in the lab to perform experiment, analyze the data. And so it was a very good training, I think almost like a PhD. And so it's a real pleasure to Alexandru the stage.
Okay. Thank you, Professor Franco, and thank you, Professor De Rosa. Thank you, committee, Mr. President, and good morning, everyone. Today, I'm going to talk about our study on T lymphocyte immunoprofiling in non-muscle invasive bladder cancer patients during Bacillus calmette-guerin immunotherapy. For introduction, we have to say that bladder cancer is the second most common urological cancer in adults in Western countries, and the invasion of the muscle layer of the bladder is a disease-defining criterion that helps us dividing this disease in muscle-invasive and non-muscle invasive disease. The latter accounts for the 75%, so the majority of the cases, as Professor Franco outlined. The non-muscular invasive bladder cancer recurrence is rather high, till 70%, and the progression rate to muscle-invasive disease is 20 to 30%. So we're talking about an important disease to define.
The mainstay surgical approach for this tumor is the transuteral resection of the bladder tumor. And the histological analysis of the surgical specimen is fundamental for the obtaining of an exact diagnosis. The degree of the invasion, as you can see, indicates the T category of the TNM staging, where the observing cellular atypias on histology indicates the grade of malignancy according to the WHO grading system. Histological and clinical data, as you can see, helps us stratify the patients in risk groups according to their probability of progression to intermediate to muscle invasive disease. We will have a difference in intermediate, high, and very high risk groups that need a close follow-up and are candidates for BCG immunotherapy. Bacillus calmette-guerin immunotherapy is the mainstay medical approach after surgery to reduce recurrence and progression of this tumor. But it was first introduced in 1921 by Albert Calmette and Camille Guérin as a live vaccine to prevent Mycobacterium tuberculosis infection. It was then hypothesized in cancer immunity in animal models in '59, and first utilized in urology by Alvaro Morales, describing it as intravesical instillation to prevent the recurrence in non-muscular invasive bladder cancer patients. Then the mechanism of BCG is still debated, but it rather appears clearly the central role of the induction of an adaptive immune response. Several studies more recently outlined how T-cell populations might be important in defining the success of the therapy. Our primary aim was to reveal and characterize the changes of the T-cell population before and after the therapy to understand if there is a change in the immune profile of the patients. Secondly, we possibly wanted to correlate the changes in T-cell population in peripheral blood with the clinical response rate of the therapy. Our design of the study included 15 patients that were included between November 2021 and June 2022. 9 patients were treated and followed up at Policlinico Umberto I, and 6 patients at the Santander Hospital. We then collected 3 different samples, blood peripheral samples, at time 0, immediately before BCG administration, at time 1, 1 week after, and at time 2, 2 weeks after initiation of the therapy. Then we controlled the recurrence and relapse of the tumor with follow-up cystoscopy at both 3 and 6 months. As you can see here, our distribution of the population reflects the epidemiology of the cancer, concentrating 80% in males and 20% in females. For each blood sample collected, we isolated the peripheral blood mononuclear cells that contained the T-cell subsets of interest. Then we stored them and analyzed them in a second moment with our innovative double staining protocol, Ki67 DNA double staining, that was introduced by Professor Di Rosa as part of the European Journal of Immunology flow cytometry guidelines. We then read our samples with the flow cytometer and then applying our gating strategy to define the population of interest. Here, I'm going to address the population that we are interested in. So from the TCD3 all T-cell positive cells, we isolated the T alpha beta and the T gamma delta that are not as far known. Then the T alpha beta cells were then divided in TCD8 positive and TCD4 positive. From the CD8 positive T cells, we then defined our subset as naive, the central memory, effector memory, and effector memory re-expressing CD45 array. Then the CD4 positive were divided in T regulatory, so Treg, or conventional CD4, and then subsequently were subdivided in the same subset as CD8 positive T cells. So our results, we observed that between comparing the time 0, so before BCG, and time 1 after BCG, we observed a statistically significant increase in 2 subsets, the CD4 and CD8 central memory subset. Then we have also to underline that these changes were present at as early as 1 week after BCG therapy, reminding that it was a local therapy and the changes were evaluated in peripheral blood. Then possibly we wanted to correlate our results with clinical response. Unfortunately, of the 15 patients 3 showed recurrence at follow-up cystoscopy. And we, comparing the results from the recurrent patient to the one that did not show relapse, we observed a trend in proliferation of the Treg cells in patients showing recurrence. Nevertheless, I would like to underline that we did not obtain statistical significance for this parameter, possibly due to our short and small sample size patients. In conclusion, I would like to underline how the changes of CD4 and CD8 central memory subsets between T0 and T1 suggest that peripheral blood can reflect a local immune response, and this is of note. Then likely these changes reflect a BCG-induced T-cell migration rather than proliferation, as we did not observe any proliferation of the subset analyzing the cell cycle phases. Then I would like to say that the Treg cells enhanced proliferation observed in the recurrence patient might suggest that Tregs have an immune suppressive function, well knowing their inhibitory function in the immune system. Considering all the said, our observations are of potential clinical interest, but they have to be confirmed in a larger study and with a longer follow-up, and we hope to continue. Thank you very much for your attention.
Sandro, I'm asking the is
Sorry, off? Okay, this was a very good question, thank you. Actually, BCG is an attenuated live bacterium, but we have seen what is called BCGs. And we did have one case of one of our patients that did show such complication. It was actually had to suspend the installation and then to retake them after the resolution of the infection. So yes, this is possible and is very important. Actually, our test is important to understand if we can prevent this from happening in some way.
Thank you very much.
Thank you.
The supervisor is Professor Lucioniesi, and I'm asking him if he can introduce the candidate. Already the title of the thesis is too long.
Okay, Mr. Chairman, good morning, everybody, candidates, colleagues, ladies and gentlemen, relatives. Filippo is a brilliant student, like all the vast majority of the students of the English course of the Sapienza University of Rome. I imagine all the students. The topic that will be covered by the thesis of Filippo deals with the FGF21, that is an important hormone mainly produced by the liver, that has a lot of direct and pleiotropic actions, and in particular, the pattern of the secretion of FGF21 during in settings of HCV infection, also after the therapy for this important disease. Please, Philip.
Professor, for the introduction. Thank you, President. Thank you, committee. Thank you also to the supervisor, Dr. Watanabe. The liver is a dynamic and visceral organ, primarily involved in exocrine functions. However, it is also involved in important endocrine activities, such as metabolism of hormones, regulation of endocrine functions, synthesis of hormone and as a true primary endocrine organ, it directly produces hormones. Among these hormones, there's fibroblast factor 21. This is a peptide hormone primarily produced by the liver, but also by other tissues such as adipose tissue and skeletal muscle. A number of studies, both in murine models and humans, have characterized the FGF21, which appears to be mostly related to regulation of metabolism. More specifically, the hormone FGF21 provokes enhancement of insulin sensitivity, increased energy expenditure, weight loss, decreased hepatic triglycerides, and regulation. Hepatitis C virus is a hepatotrophic virus exhibiting a high degree of heterogeneity. 7 genotypes have been identified. Just a few of them represent so-called epidemic subtypes, as they account for the vast majority of cases. But upon exposure and dissemination to the liver, the natural history of the disease is progression towards fibrosis, and with time, eventually to cirrhosis. So it's a clinical and histological function outcome common to a number of pathogens, which carries with itself a number of important data linking FGF21 to cirrhosis and liver damage is still scarce and quite confusing. The hormone FGF21 has been largely described in relation to cirrhosis, with the majority of the available data studies of patients affected by non-hormonal. There is general consensus over the fact that this hormone is elevated in patients with cirrhosis, but data is more confusing as patients progress with non-hormonal. Additionally, experimental studies suggest that FGF21 is elevated in present and states of today, only one study, conducted by Elsa Givertan, has attempted to describe FGF21 in a cohort of patients with genotype 4 chronic hepatitis C. They reported a decrease in FGF21 level 12 weeks after the viral eradication, direct antivirals. Considering the positive data and the studies limitations, such as the short-term follow-up and the inclusion of the wanted type, we decided to conduct a study to discover. The aim of our study was to investigate the human serum levels of the hormone FGF21 setting of the chronic hepatitis viral infection and analyze its trend upon after viral eradication. Patients were and couples with the intervention consisted in a course of second generation direct for either 12 or 24 weeks. It was based on guidelines recommendations and the extent of the irradiation. The drug used were either marketed, Cruza, or patients were initially assessed at T0 before initiation of treatment and followed up at T1 to find their sustained viral response at 24 weeks. SVR, meaning 24 weeks after HCV. T1 occurred either 9 or 12 months after the initial assessment. Patients were selected based on age and the presence of an active HCV infection for more than 6 months, whereas active cancer organ failure history, as well as other diseases, were used as exclusion. Patients were assessed with a number of investigations, including history and measured data, blood chemistry for safety, HCV viral genotype, and quantitative HCV. The FGF21 serum levels were assessed after overnight fasting with a commercially available human according to functional instructions. The last year, last fall. Here I reported the describing sample population, with a mean age of 62 and a mean disease duration of 17.8, ranging from minimum of 1 to a maximum of 38. 80% of our sample males, 71% had cirrhosis. It was our choice to include patients with variable degrees of liver impairment. Lastly, I would like to highlight the genotypes in our study. The majority of which expectedly, all patients experience HCV RNA negativity, and along with the positive movement characterized by a reduction in sickness and a reduction in markers of liver damage, so AST and ALT. No correlation was, however, found between contaminated This may be explained as transaminases are direct markers of but are only indirect markers and although included in a number of cases are looking for the detection of they can also be lack of the most relevant finding of the study was an increase in FGF21 24 weeks after this is a novel finding and is in contrast to previously reported by Elsa Girtal. These contrasting results may be explained by different definitions of sustained viral response, as it is reasonable to think that upon insult removal, we observe an initial decrease of FGF21 in the early post-treatment phases, and later on, there is a gradual increase of FGF21 as the function progressively recovers, and the synthetic capability of the liver is improved. This is similar to the very well validated marker of synthetic capability. Furthermore, similar to albumin and FGF21 was found to be negatively correlated to liver stiffness. That is in line with data existing, it may suggest a role of FGF21 and potential marker of the process. Additionally, unlike albumin, FGF21 may have both a role as a marker of the process, as well as an indicator of hepatic so you can validate it when trials these or measurement of FGF21. This may be not important for 6 times. I will just review our limitations and future perspectives. First of all, we only had one post-treatment assessment at FGF21 and SPR24. In the future, studies with serial assessment of FGF21, both early and late post-treatment should be done. Secondly, although our population was mostly composed of males, this is partly representing the current epidemiological situation as the annual epidemiological report conducted by the European Center. We decided to include several genotypes in our study, as highlighted in this table. That is, of course, accounted for a higher level of heterogeneity in our study, but rendered our population more representative. To increase homogeneity, we decided to exclude but in the future, studies should focus on different theories, as this would yield important information on the characterization and pattern expression of FGF21. Lastly, it's important for me to say that we had some missing data that were the results of the urine will report for the first time an increase in FGF21 upon improvement of movement 24 weeks after viral validation. Then we also suggest hypothesize the potential role of FGF21, potential marker of the process improvement.
Thank you very much. I'm asking the committee if there are questions or comments. There's one from Maria.
Yes. Indeed, yeah. The marker there is very little data for body part. However, increases variation, quite variations of FGF21 in different insults of the liver, both viral and non-viral. As I mentioned, a lot of data is present for but also other causes, chronic hepatitis. FGF21 work as an optimal marker. So for this,
Thank you very much. Angela, are you satisfied? Yeah. Okay. Thank you very much. We have Carlo Emerson Vasquez Barahona, and the supervisor is again Professor Micheliesi, and I'm asking him if he can.
Thank you. Thank you very much again. I'm proud to introduce Carlos Emerson, who, like Filippo, actively participated to the collection and to the interpretation of the data. The masks that we wear testify that we are in the last 2 years fighting against COVID-19, and the work that Carlos is going to illustrate is in fact a work that try to understand in part which could be the impact of cardiovascular risk factors on the response to the vaccines against COVID-19. Please.
Thank you, Professor, for the introduction. Thank you to the President of the Committee and to my co-supervisor, Dr. In recent times, we have been afflicted by two major global health issues: the immediate COVID-19 pandemic, as we've been experiencing the past 2 years, and albeit with a slower onset, we also find ourselves caught in the middle of an ever-growing obesity pandemic. Worldwide obesity has tripled since 1975, accelerated in the past decade, recognized as a decade of neglect in the prevention of non-communicable diseases. As of 2016, according to the World Health Organization, 1.9 billion adults are overweight, and if these rates are to continue, 2.7 billion are estimated to be affected by 2025. It is also important to note that obesity, defined as an excess of adipose tissue, is not well described by BMI, which is the typical index that is used in the conduction of epidemiological studies. The joint problem of these twin pandemics is further emphasized with studies in the past 2 years having demonstrated obesity to be correlated with poor outcomes following infection with COVID-19, further exacerbating the morbidity and mortality of the COVID-19 pandemic. With the development of vaccines and the rapid rollout, there is light at the end of the tunnel. However, with waning antibody titers and variable reinfection, their long-term efficacy remains unclear. Obesity, for example, has been associated with poor vaccine protection following administration of other vaccines, leading to concern over the response to COVID-19 vaccination. So ultimately, the question remains: do these non-communicable diseases also affect the vaccination response to COVID-19 as we work towards ending this pandemic? We set out to explore the gap in literature. Our primary objective was to evaluate the association between vaccination response to COVID-19 and parameters of adiposity, such as central obesity. Our secondary objective was to evaluate the association between vaccination response and other risk factors, such as hypertension, smoking, diabetes, and dyslipidemia. As for our methods, in January to February 2021, subjects were to receive 2 COVID-19 mRNA vaccines, approximately 21 days apart. Prior to enrollment, as part of our inclusion criteria, subjects underwent venous sampling to ensure that they were indeed infection naive. Blood was drawn before the first dose and approximately 1 to 4 weeks after the second dose, and mRNA antibody titers were evaluated using a commercially available assay. Data was collected with structured interviews throughout the study, and body parameters such as weight and waist and hip circumferences were recorded at baseline. In addition, body composition was performed by use of DEXA scans. These are the descriptive characteristics of our study population. We enrolled 86 subjects into our study with a median age of 29 and a median BMI of 22.4, of which 63% of our study population were of normal weight, 27 were had overweight, and approximately 10% were affected by obesity. 31.7% of our study population were smokers, and 15.3% had hypertension, which was controlled under antihypertensive management. A small proportion had diabetes, and 7.1% had dyslipidemia. So we decided to give an emphasis to waist circumference, which well defines central obesity and excess adiposity. Here we have a scatter plot that illustrates the correlation between anti-SARS-CoV-2 antibodies and waist circumference as the independent variable. We found that even in a mostly lean population, higher waist circumference was associated with lower antibody titers. Indeed, potentially because our BMI distribution was low, we did not find a correlation between antibody titers and BMI. But again, I'd like to point that BMI is not an ideal measure of obesity. Here we have some box plots that illustrate the direct comparison of a few other variables. For example, in figure B, we have the direct comparison of smokers and non-smokers, with smokers having lower antibody titers than non-smokers. Similarly, illustrated in figure C is a direct comparison of hypertensive subjects and normotensive subjects, with hypertensive subjects having, again, lower antibody titers. And the same holds true in figure D, with those with dyslipidemia having lower antibody titers than those without dyslipidemia. As for our study's strengths, the base population of our study consisted of healthcare professionals, which were among the first to be vaccinated. Hence, these were some of the first real-life results available. In addition, waist circumference is cheap and easy to detect, and it does not require any further instrumental examination, thus suggesting a possible immediate clinical applicability. As for the study's limitations, our sample size was relatively small, and multiple comorbidities were underrepresented. The BMI distribution was relatively narrow, although it did reflect the prevalence of obesity in the
Help.
As for my concluding remarks, while some countries have yet to fully vaccinate their populations with a booster dose, others are already considering the possibility of a fourth. And I'd just like to reference an example used by Professor Rino Rapoli, presented at the World Health Summit regional meeting this month held here in Seduta, in which it is demonstrated that higher levels of antibody concentrations are required to neutralize newer variants of COVID-19, with the dominant Omicron variant, for example, requiring about 40 times as much to be neutralized. So with falling antibody titers and higher level amounts needed, it could be a cause for the poor long-term efficacy of these vaccines and the increased prevalence of reinfection. So while immunity is, so whether immunity is to be achieved using new specific variant-specific vaccines or mixing vaccines is still to be determined, but the identification of specific vulnerable populations could help define future vaccination schedules, especially with the likelihood of endemic disease and the possibility of new variants. So I'd just like to reiterate the importance of retaining a vigilant approach to the vaccination response as the ongoing pandemic ensues. Thank you for your attention.
asking the committee if there are questions or comments. Comments? Actually, I have to say that I have seen, unfortunately, many patients, critical patients with COVID-19, and most of them were obese. I thought that the reason was because they had respiratory problems, but I think the problem is the immune response, because I think like for the vaccine, for the disease as well, they're going to have a less immune response. Is that right?
Thank you for the comments. I do agree. There have been studies that have demonstrated a dysregulation in the immune response in obese patients, particularly because of their visceral adipose tissue. And it is also true that obesity is a poor indicator for the ability to intubate the patient. So you can see that obesity could be affecting treatment in a variety of different manners.
Okay, thank you very much. All the audience, please to stay on your seat in silence. We go outside the committee for 5 minutes and we will be back on the program. look at me, but the audience, your relatives, friends, turn around, you can see you. You can see I'm more anxious than you are. And it is always touching therapy, that one. And I have to do a little speech. Even though I'm a surgeon, good surgeons say few words and put a lot of stitches. And so, don't worry, I will be very fast. I have to do some advice to those students, because they are still students. First of all, keep these energies and this enthusiasm. I got my degree 34 years ago, and my enthusiasm has increased in these 34 years. And I wish you the same thing. Don't put limits in your career, because life has more fantasy than we have. I would have never thought to be here as a president of such a committee, and you will be in my place one day. Other few advice: have respect for your patients, first of all, for your colleagues, second, and for your parents, relatives. Have for them gratitude, because they did a lot for you. They worked hardly to have you in this situation. Don't look in the future for power, glory, or money. You have to look for a thank from your patients. If you will see a thank in the eyes of your patients, you will have reached your aim, because your aim will be in the future the patient. That's all regarding me. I have to ask Dr. Maria Grazia Tarsitano, who should be from remote. She's on behalf of Medical Association. If she wishes to say something to these dear doctors. Okay. Unfortunately, she's from remote and she can't say anything. She's on behalf of Medical Association, Italian Medical Association. If you want to be a doctor in Italy, you have to be in this association. So for the foreigners, if you want to work in Italy, you are welcome, but you must be part of the Medical Association of Italy. And remember that you're not student anymore, because the degree now allows to work. So tomorrow you can be a doctor and you can save lives.
Good morning. I hope that the line now is good. Are you able to hear me? I'm Maria Grazia Tarsitano.
Can you hear me?
Yes, now I can. I'm sorry for this trouble my line, but I want to say something to this student. Your word was amazing. That thank you, President, for your word, and to say welcome to these new colleagues. I am proud to be as a representative to the Order of Physicians of Rome, and it's every time a pleasure to be part of this committee, and because the level of the thesis are so high, And I want to say welcome to this student because they will perform the best job of the world, and they have to enjoy it every time. Also, well, will be just a little hard. And I want to do the compliments to this new colleague and your family, because it's a really important day in their life, but it's only the first day of the a life that they will be every day in with and for their job. I want to say that we will perform a journal for the to be able to work, and it will be in the 7th of July. So, dear colleague, you have to perform what you find on the our website, and you will be able to perform your job from the 7th of July. I'm really sorry for this trouble that I did this morning, and I want to say goodbye to everyone.
Thank you very much. Last thing I forgot to say, my student told me yesterday that today is the last day I'm your student. That's not right, because all of you are going to be our students forever for your professors. So you can turn around, please. Gabriele Celeste. I proclaim you doctor in medicine and surgery with 97 out of 110. Congratulations. Shir Bergman. I proclaim you doctor in medicine and surgery with 104 out of 110. Congratulations. Ilianos Rikis. Which is the name? I proclaim you doctor in medicine and surgery with 108 out of 110. Congratulations. Nada Barak. I proclaim you doctor in medicine and surgery with 110 out of 110. Embe Surel Luciani. I proclaim you doctor in medicine and surgery with 110 out of 110. Congratulations. Alexandro Turcan. I proclaim you doctor in medicine and surgery with 110 out of 110. Congratulations. Simone Madeleine Leithausen. I proclaim you doctors in medicine and surgery with honors. Congratulations. Merv Onkaya. I proclaim you doctor in medicine and surgery with honors. Adam Applebaum. Proclaim you doctor in medicine and surgery with honors. Emerson Carlos Daniel Vasquez Barahona. I proclaim you doctor in medicine and surgery with honors. Margherita Di Giorgi. I proclaim you doctor in medicine and surgery with honors. Gaji. I proclaim you doctor in medicine and surgery with honors. Emanuela Urda. I proclaim you doctor in medicine and surgery with honors. Ilam Azel. I proclaim you doctor in medicine and surgery with honors. Sultana Mustafa. I proclaim you doctor in medicine and surgery with honors. Francisca Dutra. Doctor, medicine and surgery with honors. Amra Daniel. I proclaim doctor in medicine and surgery with honors. Matteo Calafat. I proclaim you doctor in medicine and surgery with honors. Now, as the tradition wants, the best graduated today is going to read the Hippocrates. And come here. You have to wear the hat. You can come here. I told you one day you will take my place. It's a bit early. Hippocratic oath. I swear by Apollo. Again, Hippocratic oath. I swear by Apollo, the healer, Ashlepi, Igeia, and Panacea, and I take to witness all the gods, all the goddesses, to keep according to my ability and my judgment the following oath and agreement. To consider dear to me as my parents him who taught me this art, to live in common with him, and if necessary, to share my goods with him,
To look upon his children as my own brothers, to teach them his art. I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. I will not give a little drug to anyone if I must, nor will I advise such a plan. And similarly, I will not give a woman a tessary to cause an abortion. But I will preserve the purity of my life and my heart. I will not cut her stone, even for patients in whom the disease is manifest. I will leave these operations performed by practitioners, specialists in this art. In every come, I will enter only for the good of my patients, keeping myself far from all intentional ill-doing and all seduction, and especially from the pleasure of love with woman or with man, be they free or slaves. All that my knowledge in the exercise of my profession or in daily man, which ought not to be spread abroad, I will keep secret and will never reveal. If I keep this faithfully, may I enjoy my life and practice my art, respected by all men and in all times. But if I swerve from it or violate it, may the curse be my lot.
Thank you very much, everybody. I really enjoyed this session. I'm proud of the students and of the audience. We were very good audience. Bye bye.